ಒಂದ್ಸಲಿ ಫೋನ್ ಮಾಡ್ಬಿಡ್ತೀಯಾ ಪ್ರಶಾಂತ? ಲಕ್ಷ್ಮಣ್ ಸರ್, ಸರ್ ಬಿದ್ರಿ ಸರ್, ಬಿದ್ರಿಗೆ ವಾಲ್ಯೂಮ್ ಕೊಡು. ಬಿದ್ರಿ ಸರ್, ಕುಟ್ರೆ ಸರ್, ಪ್ರತಾಪ್ ಚಂದ್ರ as usual first batsman.
ಓಪನಿಂಗ್
all the best.
ನಿಮ್ಮ ಆಶೀರ್ವಾದ ಬಾಸ್.
ಇಲ್ಲ, almost today I am expecting around 350 to 400 people will go more in the Zoom.
Very good.
And another 150 people will be there in the Facebook.
Super.
And I'm expecting more people. So your batting should be solid.
100%. Hope we will meet to the expectation.
Please, please. Pradeep, Dr. Pradeep.
ಅವರು ಆಗ್ಲೇ ಪ್ಯಾಡ್ ಕಟ್ಕೊಂಡ್ಬಿಟ್ಟಿದ್ದಾರೆ.
ಇಲ್ಲ, ನೀವಿಬ್ರೆ ಫಸ್ಟ್ ಬ್ಯಾಟ್ಸ್ಮನ್ಸ್, ನೀವು ಅವರು.
ನಾವು ರೆಡಿ.
ಸೊ ನೀವು ಫಸ್ಟ್ ಬೌಲಿಂಗ್ ಅವ್ರು ಫೇಸ್ ಮಾಡ್ತಾರೆ, ನೀವು ಇದ್ ಕಡೆ ರನ್ನರ್ ಅಲ್ಲಿ ಇದ್ದೀರಾ. ಓಕೆ, ಸೊ ಪ್ಲೀಸ್ ಪ್ರಿಪೇರ್, ರೆಡಿ ಟು I am expecting more than 400 people will. That's what we have given the publicity to all the people about your group. So please.
Thank you, sir.
Okay.
Thank you.
Rajat. Prashant.
Rajat is there. Rajat?
ಕೇಳುತ್ತಾ?
ಕೇಳಿಸ್ತದೆ.
Okay.
Raj, the Clooney.
Rajat is full adjunctive therapy. It is like giving many multiple injections to make the brain like that. Your talk should be you should keep the audience till the end, dear.
Okay. ನೋಡೋಣ.
Your talk should be more enthusiastic to keep the more people.
Sure, Dinaka.
Yeah, please.
Definitely.
Bidari sir. ಎಲ್ಲಿ ಬಿದ್ರಿ?
ಇದರ ಸರ್, ಯಾಕೋ ಆಡಿಯೋ ಬರ್ತಾ ಇಲ್ಲ. ಒಂದ್ ನಿಮಿಷ ಸರ್, ಅವ್ರಿಗೆ ಕಾಲ್ ಮಾಡ್ತೀನಿ.
ದಿನಕರ್ ಸರ್,
ಎಲ್ಲಿಪ್ಪ ನೀನು?
ಸರ್
ಎಲ್ಲ ಬಿದ್ರಿ ಸರ್.
ಸರ್ ನಮಸ್ಕಾರ.
ಕಾರಲ್ಲಿ ಕೂತಿದ್ಯಾ ಮಗ?
ಮಳೆ ಕೇಳಿಸ್ತದೆ, ನಾವು ಮಾತ್ರ ಕೇಳಿಸ್ತದೆ ಸರ್.
ಗಾಡಿ ಓಡಿಸ್ಕೊಂಡ್ ಮಾಡ್ಬೇಡಪ್ಪ.
ಇಲ್ಲ, ನಮ್ದೆಲ್ಲ ಲೈಟ್ ಹೋಗಿ ಬಂದು ಅದಕ್ಕೆ ನಮ್ ಕಡೆ ಒಡೆ ಬಂದ. ಒಂದ್ ಮಿನಿಟ್ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ತೀವಿ.
ಇರಿ ಸರ್. ಪ್ರಶಾಂತ್, ಇದು ಸಿದ್ದು
ಸರ್, ಗುಡ್ ಆಫ್ಟರ್ನೂನ್.
Sidhu, please tell all the PGs because today talk is very, very nice. It will be very nice talk. Bidri sir.
Yes sir. Sir, 15 ಜನ ಲಾಗಿನ್ ಆಗಿದ್ದಾರೆ ಸರ್.
ಅಲ್ಲ, ಒಂದೇ ಟಿವಿ ಅಂತ 10 ಜನ ನೋಡೋದಲ್ಲ ಕಣ.
ಇಲ್ಲ, ಇಂಡಿವಿಜುವಲಿ ಲಾಗಿನ್ ಮಾಡಿಸ್ತಾ ಇದೀನಿ ಸರ್.
ಮತ್ತೆ ಅದೊಂದೇ ಅಲ್ಲ, ನಾಟ್ ಲೈಕ್ ದಟ್. Everybody should listen. Don't keep the phones or go away. That comment I didn't like.
ಮಾಡಿಸ್ತಾ ಇದೀನಿ ಸರ್. ದಿನಕರ್ ಸರ್, ಲಾಗಿನ್ ಮಾಡಿಸ್ತಾ ಇದ್ದೀವಿ.
ರಾಘವೇಂದ್ರ, ನೀನೇ ಲೇಟ್ ಕಣೋ.
ಸರ್ ಇದೀನಿ ಸರ್, ಐಸಿಯುದಾಗಿದ್ದೀನಿ, ಮಾಡಿಸ್ತಾ ಇದೀನಿ ಸರ್.
ಮತ್ತೆ ಪ್ರಸಾದ್ ಎಸ್ ಸಾರ್ಗೆ ಸ್ವಲ್ಪ ಹೆಲ್ಪ್ ಮಾಡು.
ಮಾಡ್ತೀನಿ ಸರ್, ಪ್ರೆಸೆಂಟ್ ಮಾಡಿದ್ದಕ್ಕೆ ಸರ್. ಮಾಡ್ತೀನಿ ಸರ್, ಮಾಡ್ತೀನಿ ಸರ್.
ಎಸ್. Today I am expecting more than 350 to 400 people will log in. Many people.
Yes.
Prashant? Dr. Prashant? Prashant?
Thank you. ಬಲ್ಬ್ ಟೈಟ್ ಮಾಡಂಗಿಲ್ಲ.
ಕೇಳಿಸ್ತದೆ, ಅದು ಇವ್ರಿಗೆ ಫೋನ್ ಮಾಡ್ತಾ ಇದೆ ಸರ್.
Prashant?
ಸರ್.
Can you put that slide, second slide, please?
Okay, sir. Okay.
Second slide. So, my dear friends, today I am not propagating any company or any product or anything. At present, in our hospital, we are using this. Probably many people are using many companies, but ultimately at present, when they are using this, it's a very good critical machine is there. Pratap, second one. Hello, Prashant, second one.
ಇಲ್ಲ ಸಿದ್ದು
Second slide.
ಬರ್ರಿ ಇಲ್ಲೇ ಕಾಂಗ್ರೆಸ್ ಅಲ್ಲಿ ಇದು ನಮ್ಮ ಇದಕ್ಕೆ ಗೊತ್ತಾ
This is OBM machine.
ಬರ್ರಿ ಬರ್ರಿ
So this one they have done even in artificial intelligence as well as the camera also. So even you can do the AE with the camera as artificial intelligence also there. The same thing. Good. Only thing you should bargain with the company for the procurement. For our all the talks, these machines will be useful. Prashant, previous slide.
ಇಲ್ಲ ಬರ್ತದೆ
Previous, first slide. Yeah.
Prashant, I think we can mute all others. Yeah, I'll do that.
Slide
There's a lot of chaos. I think people will start leaving. ನಂದೋಗಿಂದ ಕಳ್ಸಿ ಡಿಪಾರ್ಟ್ಮೆಂಟ್.
एंटीवायरस स्लैब्स आ गया था
आ गई अब आ रही है अब नहीं आ रही अब
ना आनंद लास्ट टाइम आते
Dr. Prashant.
हाँ सर
I think so. 250 members have joined. You can start here.
You can start.
Kutresh sir, now start ಮಾಡಕ್ಕೆ ಹೇಳು. Kutresh sir.
1 second sir.
ಅಷ್ಟಕ್ಕೆ ಯಾರು ನೋಡ್ರಿ
Bidari sir, ನಮಸ್ಕಾರ.
ನಮಸ್ಕಾರ
ಒಳ್ಳೆ ಬ್ಯಾಟಿಂಗ್ ಆಡ್ಬೇಕು ಇವತ್ತು. Hello sir.
Dinakar and Prashant, good evening.
Good evening sir. Good evening.
Many will join. Very important topic, and many have started practicing it. I think wonderful session. Because you have 4 speakers, you better start now. It's 5:10.
Yeah, we will start now. We'll start. We welcome all the participants who have logged in for this meet on behalf of NNF Karnataka chapter, and this has been continued from last 2 weeks. A very good and excellent response. And participants have logged in from all over India and even outside India. So without wasting much of time, we will move to our academic session now. The first talk will be by Dr. Pratap Chandra, is a consultant neonatologist at Motherhood Hospital. So Dr. Pratap. Dr. Pratap? Yeah, you can start sharing the slide. So today, the entire topic, all the 4 sessions will be on therapeutic hypothermia, about everything about therapeutic hypothermia. And this,
do you see me?
From science to the personal experience. So today we have Dr. Pratap Chandra, Dr. Pradeep Gcm, Dr. Rajat Athreya, and Dr. Bidari sir. So all of them are well-renowned across India, and they're going to talk on therapeutic hypothermia. It's going to be a complete package of therapeutic hypothermia. Over to you, Dr. Pratap.
Thank you very much, Prashant. Thank you very much, NNF Karnataka, for such a lovely opportunity that you guys are giving us in spite of the lockdown. Without further delay, I would like to start the talk. But before doing anything else, I would like to show you, this is Vishna Rasaya. He was a very, very good friend of mine, and he was a mentor to me. He's the one who handheld me, and then during my training days in England, and he was a very, very brilliant teacher. More than anything else, he was a fantastic human being. His legacy was that, this teaching, training, and helping people should be carried all the time. And I would like to start my talk by giving a naman to him and then saying, I will continue the legacy. Sorry, I'm just being a little emotional. Dr. Vishna died because of coronavirus infection just last week. And this talk I'm dedicated towards Dr. Vishna, and may his soul rest in peace. Right. As we all know, brain is extremely complex, and the growing brain is very fascinating. And whenever we have this growing brain, and if there is an insult to this growing brain, then I think everything will go complete haphazard. And this is what we all fear about, is resulting in either death or developmental delay. Until recently, we did not have any answer to how to treat this kind of a condition except for giving intensive care. But of late, therapeutic hypothermia has been one of the modalities of the treatment in treating birth asphyxia or HIE. I'm just going to stick to some of the basic things about the therapeutic hypothermia. How do you select? Some of the pointers that I will give you based on our own experience. And we have also had a team called NCAT, which is Neonatal Cooling and Transport Group. And through this group, we have been propagating total body cooling and management of hypothermia, along with the transport to the entire state. And this is under the auspices of the NNF Karnataka. So during this talk, I would like to take you through to some of the will not bore any one of you, and therefore I will keep everything to a little succinct points. A brief history of one of the baby. What is the evidence that we have? How do you do the assessment and referral? This is extremely important. And the criteria to select a baby for cooling is very well established, and I would like you to know about that. But like anything else, any therapy has got gray areas in this. So I would like to discuss a little bit about the gray areas that is surrounding this sort of a therapy, and also some of the pearls that I'm going to give you about managing HIE. I'm also aware that amplitude EEG is taken by Dr. Pradeep. He's extremely well knowledgeable about that. I'm not going to touch anything about it. And Dr. Rajat is going to talk about the adjuvant therapy, as well as how do you monitor. Again, those things I will keep. So just 1 second. So whenever a baby has an insult, okay, which is either due to hypoxia or due to ischemia. So a mother has, undergone some sort of a problem, and this baby inside is struggling, and it's not getting enough blood supply, on the other hand, enough oxygen supply to its brain. So what it does, it mounts a very bad cascade of response, which is called as an injury cascade. So with hypoxia, there is going to be an immediate energy depletion. We all know oxygen is the mainstay for your ATP in undergoing aerobic metabolism. And if you don't have enough oxygen, there is a very quick energy depletion. So with that energy depletion, first thing that is going to happen is your cells going to die. So that is called primary cell death. I will give enough opportunity for people to give, ask about the questions later on. Right now, I think I'll just keep talking. And with this, what happens? There is increased release of free radicals. These free radicals can be oxygen species or nitrogen species. And also brain gets into a state of excitatory mode. So this is called as excitotoxicity. Some certain amount of excitement is always important, is always good, but excitotoxicity is not so good. And then because of this, there is huge consumption again of lots and lots of energy, wherein it results in a secondary energy failure, right? So this will result in a delayed cell death. So there's a primary cell death and there is a delayed cell death. Then if you look at it, one of the best studied amino acids is glutamate. So glutamate is one of the brilliant neurotransmitter which is required in almost all the parts of the brain. So when there is HIE, what happens? There is profound disruption in the function of these glutamate synapses. This will immediately hamper or impair the reuptake of the glutamate, right? Say, for example, if there is a hypoxic event, it preferentially depolarizes your the neuronal membranes. Hypoxia depolarizes your neuronal membranes. Ischemia will have a profound impact on the reuptake of these glutamate. So both this phenomena results in higher amount of excitotoxic glutamate that is present in the brain that these babies need to handle now. So generally speaking, glutamate is very good and helps in progenitor cell proliferation. It helps in the differentiation of the cells. It tells which place which neurons need to go in. It helps in the neuronal migration. It also helps in the survival of the cell. But as we say, too much is too bad. So when there is lots and lots of glutamate present, it worsens the calcium influx into the cell. It sets up a pro-apoptotic pathway. You all know apoptosis is nothing but suicide. So the cells enter into a state of suicidal tendency, and then it starts dying. When this happens, there is free radical formation. Free radicals further worsens the damage of the cells. Along with this, there is lipid peroxidation. So lipid is extremely important for your myelination. So when you do SPECT scans, you will know the choline peaks will be very, very high. That suggests that your myelin is damaged. So your lipid helps in development of your myelin, and destruction of that is set up by this excitotoxic glutamate. All this unfortunately results in a very profound and widespread brain injury in the baby, right? This is all pathophysiology I'm going to talk about. I'm not going to bore much about this because there is a lot of free radicals, etc., etc., etc. Then coming to what is the evidence that we have got. See, as I was suggesting, this is one of the best studied therapy in the whole world in the last couple of decades. If you look at it, the previous to this we can boast of is the study on the steroids, the antenatal steroids. So this is a study which has changed the way we look at and treat hypoxic ischemic encephalopathy. So some of the studies, just to list it: CoolCap trial. So I was lucky to be part of it in Liverpool, where they just cooled the head and didn't do anything to the body. The NIHCD, famously headed by Sita Shankaran, Toby trial headed by Dennis Azzopardi, Euro Network, the ICE trial from Canada, Australia. So all these trials have got very similar inclusion criteria. There is a little difference here and there. Say, for example, some trial have taken base deficit as more than -12. Some majority of the trial have taken base deficit of more than 16. So either ways, both of them are suggestive of severe hypoxic ischemic damage to start with. And the clinical criteria were very similar, but trials like Toby relied quite heavily on amplitude EEG as well as one of the criteria to select a baby to be eligible for cooling. So again, I don't want to bore much into these statistics. So getting in, what does this evidence show? This is your forest plot diagram, various studies that has been listed on the left, and the results are on the right. Anything to the left of 1.0 is favorable. And the last one, which is the big diamond, which shows here, this is the cumulative response of all the studies. And the width of the study and the width of the diagram suggests the number of babies that has been recruited overall in the trial. So it does suggest that it is very favorable. So what is the summary of my studies that has been explored? It favors hypothermia for death or neurodisability at 18 to 22 months of age. It increases, what is this? This hypothermia increases the rate of normal survival. It lowers the death and severe disability at the school age. The number needed to treat, however, was very small, 6 to 9. Some studies had 6, some had 7, some had 9. What does it say? It means only about 7 babies needs to be cooled for 1 baby to get huge benefit. This is extraordinary result. This is very, very good. in the situation where we didn't have any clue as to how to manage these kind of babies with HIE. Right. So what is this HIE burden in India? So majority of these have come from the Western studies. So in the Western data suggests neonatal encephalopathy. I'll come to neonatal encephalopathy, why I'm calling that NE. It's about 2 to 9 per 1,000 live births. But when you come to moderate to severe HIE, it's about 1 to 2 per 1,000 live births. But look at India. It's almost, developing nations have got 10 to 60% higher. When I go to a lot of peripheral hospitals, in a lot of places, I get really worried. The major diagnosis is meconium aspiration, HIE. Meconium aspiration, HIE. Almost about 70–80% of their admissions were meconium aspiration, HIE. This suggests the burden of HIE in India. And unfortunately, majority of the HIE happens in very low socioeconomic strata. This is reflected by the education status of these people, the kind of awareness that they have got. So it's a combination of all this. And majority of the babies, unfortunately, again, are born in low resource settings. They don't have settings even to ventilate and to be acting like a level 2, level 3 centers. So these are the places where these babies are born. Not to forget the PHCs or even home deliveries, right? And again, when you look at the burden in India, it's just to look after this kind of a huge burden. The training and the resources available is very, very minimal. It's quite abysmal at this point in time. So this is where the awareness needs to go more and more. So look at this. There is this one. This is one of the babies that was referred to us from 90 kilometers away. I'll just give one example of this study and then go on to HIE properly. Okay. This was an uneventful antenatal period. I would like people to use your chat and then say yes or no if you have seen these kind of babies in your lifetime. Right. Uneventful antenatal period. A term baby boy. Mother came to the hospital with loss of fetal movements for about 4 hours. There was a meconium stain amniotic fluid. CTG, what I meant is an NST in India, was abnormal. They refused cesarean section. I'm not sure why. I'm sure you all know why. It's a very common scenario. But finally, after an hour of counseling, they agreed to it. And then there was a big abruption noted retroplacentally, right? Then the condition of the baby at birth, there was no cry, no spontaneous breathing. The heart rate was less than 60. The PG who was there did IPPV and intubated the baby. UPCARs were noted to be 1, 3, and 5 at 1, 5, and 10 minutes respectively. The baby was put on this only ventilator that they had. The saturations were about 92% in 100% oxygen, and the baby was having quite irregular sort of breathing, and he started noticing seizures and a little bit of opistotonic abnormal posturing. How many of you have seen these kind of circumstances? How many of you are dealing with this day in, day out? You can say yes or no in the chat section. I can't see the chat section actually here. So I would guess in these circumstances, majority of the people, so 3 participants raised their hands. So that's fantastic. I think, I'm sure majority of you would have experienced this at least once in your lifetime being a pediatric trainee. The number is going up and up and up. So this is a circumstance where we have a baby, a very sick baby born, and then it's not cried. Its UPCARs are quite bad, and this baby is ventilated. We also started noticing seizures, right? What do we do with this kind of baby? So we encounter these kind of babies. The next question is, should we cool this baby? Should we not cool this baby? Where do I refer? Can I handle this baby in our own unit? These are the things that come, just in front of you, just comes cascading in front of you. So what I would do is with the next few slides, go through HIE and then try and make you understand what are the things that you need to do here. Right. First and foremost is assessment of the baby. So you've got a baby here, you need to assess. In my opinion, any assessment should start with antenatal risk factors. So when you go to the delivery, you find out, is there any antenatal risk factor for this baby? Then what I call is perinatal sentinel events. So these sentinel events are extremely important. That's priceless because it gives you a clue as to what has happened to the baby, and it also helps you in getting prepared. And the baby is born postnatally. How do you do the neurological examination, and what is the criteria of cooling that you're going to see whether this baby fits into the criteria of cooling, whether it needs cooling or not. I hope I'm clear so far, right? So antenatal risk factors, what is it? Low socioeconomic population. We all agree that. Placental insufficiency. Is there any placental insufficiency in this mother? Is the baby very IUGR or even large for date babies? Large for date especially happens in maternal diabetes because you have significant amount of cephalopelvic disproportion. When that happens, we know the birth-related injuries are more. The baby's head can come out and the body can get stuck, what is called as shoulder dystocia. And we have been there. We have encountered this quite a lot of times. And if there is any PIH or eclampsia, this is a state wherein the baby is almost compromised inside, especially if mother had any, what do you call that, seizures as well. So then the health of the baby is quite compromised inside. So these are the antenatal risk factors you should keep in mind. Then coming to your perinatal risk factors. So what are the perinatal risk factors? We call this as sentinel events. Okay. So when you look at this, loss of fetal movements, CTG abnormalities or NST abnormalities, any ruptured uterus, that is a red flag sign. This is not just dangerous to the baby, but it is also dangerous to the mother. Severe abruption. Unfortunately, abruption sometimes is not seen unless the baby is delivered and you're delivering the placenta. Then you notice a big cake of clotted blood coming out. Vasa previa, severe maternal-fetal hemorrhage, umbilical cord prolapse. So all these form a sort of sentinel events. If any of this is there, your obstetrician should highlight this. Doctor, these are the things that I'm expecting from this baby. And any of these risk factors, the babies tend to pass meconium inside. And with all these risk factors, the baby is breathing inside. It tends to develop fetal distress and starts having gasping respiration. With a gasping respiration, all the meconium gets inside, what leads to the meconium aspiration syndrome. I hope I'm not going too fast or too slow here. So moving on, the sentinel events. Why is this important? So there was a good retrospective review of about 182 babies with neonatal encephalopathy in Canada. So what did they do? They looked at babies who were cooled, and then they found out 30% of the cases, that's quite staggering, that's quite a lot of number of cases, had sentinel events. If you want to say the glass is half empty, you can always say in 70% of the cases, nobody had a clue about HIV. So that is also true. And then most commonly was noted was abruption or your CTG abnormalities. Then what happens if there is a sentinel event? Why is it important? See, a baby is born with HIV. If there is a sentinel event 5 minutes, 10 minutes, half an hour ago, you know the timing with which you can start the cooling, right? I will tell you why that is important. When they looked at these babies who had sentinel event, most of them had a favorable outcome. And a lot of them had gray matter injuries, especially involving the basal ganglia and the thalami region. Why? Any sentinel event, the first hit that is taken up by gray matters, the gray cells. And then when they followed up these babies, majority of these babies did very well. Some of these babies developed what is called as your athetoid cerebral palsy, right? And those babies who had absent sentinel event, they had delayed development as well as cerebral palsy. Numbers were increased in these babies. So how do you correlate this? What I meant by sentinel event is, you know there is an abruption at 5 o'clock. Baby is delivered 5:30. And you start cooling because the baby met the criteria from 2 hours of age. So you know it is 2.5 hours from the time of having that event. If there is no sentinel event, this baby might have had few episodes of chronic events. So therefore, you cannot time these kind of, the timing for deliveries, as well as the timing for initiation of cooling. And these babies who did not have sentinel events or chronic events, they happen to develop white matter injury, which was significant. along with the injury of your plic, what is called as posterior limb of the internal capsule, which almost always resulted in significant cerebral palsy. So acute injury, which worsens your gray matter injury, but for chronic insult, your cerebral reperfusion keeps happening. There is an insult, cerebral reperfusion, insult, cerebral reperfusion. So over a period of time, these gray matter injury improves, but then the white matter injury becomes more. I think when Dr. Rajat speaks about it, he will speak more about MRI and other changes. So now we need to assess this baby at the time of birth. We looked at the antenatal risk factor, we looked at the sentinel event. Assessment at birth, condition of the baby at birth, whether it cried or not, very, very important. None of the term babies should be born without cry. This is dictum. So they should be born with cry. Need for IPPV or full resuscitation. See, I would always like to emphasize a point here. A term baby not crying is not good. You call it as resuscitation. A preterm baby is not crying or weak cry, you help them. That is called stabilization. Very, very important to know. Resuscitation, stabilization. So none of the term baby needs stabilization. They need help, means it is called resuscitation. And depends on whether you've used the drugs. We have an acronym for the drug called BAD. B, bicarbonate, A, adrenaline, D is for other, the dextrose and other sort of drugs. So when you've used these drugs, the outcome is not going to be good. Assessment also includes some sort of a blood gas. You know, the studies suggest it can be either arterial, cord blood gas, even capillary blood gas within first hour of life. UpGars. So again, you know, if the baby is born at home, we can't help it. You know, at least the description of it should be, undertaken, and you have to ask for this kind of an history from whoever was present at the time of the birth. At least major things they are able to tell you. And then you look at the weight as well. So this is again objective. So objective evidence is your weight. I'll tell you why weight is important, especially when the gestation is not known, especially you think there is a gray area. Now you have assessed the mother, you have assessed the baby at the time of birth. What about the postnatal assessment? The postnatal assessment means you've resuscitated a baby. The baby is transferred to the NICU because the baby is looking not so good. So what do you do? What do you do at that point in time? You do your neurological examination. So the neurological examination, the dictum, the thing that we follow most commonly is your Sarnath scoring, the modified Sarnath scoring, which tells you, that's why I tell all my people, you know, don't have to by heart everything. You can take this with you and then see which area the baby fits into, whether it's a moderate encephalopathy or a severe encephalopathy. The seizures just straight away puts your baby into moderate encephalopathy. Without any evidence of anything, seizures will put you into moderate encephalopathy. Okay? Then a baby is lethargic, very decreased tone, dull, not so much activity. And then the pupils are not reacting that well and constricted. And then having a little periodic breathing. This is moderate. Severe is very, very easy. Anybody can say it's stuporous, it's comatose, it's having a decerebrate rigidity. It's very flaccid. You know, the baby should be really like a position like this, and then it will be very floppy. That shows you that the baby has got a very severe encephalopathy. So you need to assess whether your baby belongs to moderate or severe encephalopathy. I'll come to the mild one in a bit. Right? So systematic assessment, antenatal, perinatal at the time of birth, then postnatal assessment. Then you have all this with you, then we will see what is the criteria for cooling. You need all this absolutely to decide, okay? So then, any signs of perinatal asphyxia is there or not, you need to establish. How do you do that? Baby should be more than 36 weeks of gestation at least. I've written in the bracket as 34 weeks. I'll come to that in a bit. Assessment of the baby for the cooling criteria should be done. The baby should fulfill, there are two criteria in this, criteria A and criteria B. And I'm not forgetting Dr. Pradeep here, amplitude EEG. When he's going to talk to us and tell us all about it, amplitude EEG is extremely helpful, very objective, very easy to understand. So if you have that as well, as an adjunct to you, then it's going to be very beneficial. So now, you look at the criteria A. What is the criteria A? Criteria A defines everything about how the baby's condition at the time of birth. So you should have at least one of the following, which is Apgar, 5 at 10 minutes of birth or less. Continued read of resuscitation. I told you, anything, either ET or mask ventilation, because none of these babies should have any problems in crying. If they're crying, not crying, then there is a problem. Acidosis within 60 minutes of birth. Again, how do you define acidosis? You need a blood gas, where your pH will be less than 7, base deficit is more than minus 16. I have taken this criteria from Toby. For example, I told you NIHCD and even the ICE trial used more than minus 12 as the base excess for one of the criteria. And this is any blood gas within the first 60 minutes of life. So criteria A, please keep in mind, it is all about the condition of the baby at the time of birth and how bad it is. Coming to criteria B, it is all about its clinical finding, your examination of whether it's a moderate or a severe encephalopathy. Already I told you, if there is fits, it fits into moderate encephalopathy anyway. But I have a little problem in this. A lot of people think movements of the babies as fits, jitteriness of the babies. A lot of these babies, even with mild encephalopathy, are very, very jumpy in nature. You touch and then they're jumpy. And then sometimes they just have this a little bit of a clonus, into their movements as well. Don't always say this is a seizure, okay? Documentation of seizure is extremely important medico-legally as well. And also, that cascades into you starting a lot of therapy, whether it is going to be your phenobarb, phenytoin, levetiracetam, whatever it is, you keep adding medicine after medicine. So accurate diagnosis is key. One of the things I always suggest is take a video clipping. That is going to be very beneficial. Whether you are in doubt, we are all in doubt. This is not something which is very easy. We are all in doubt. Sharing that with a tertiary center, if you're not cooling, or sharing with your colleagues is going to be very, very helpful. So how do we define criteria B? Altered state of consciousness, right? Reduced response to stimulation, or even absent. Very abnormal tone. You pull the hand of the baby, it should recoil. It should recoil. But if it is not doing, you pull and it just falls off. That is not good. It's very, very abnormal if the tone is very less. Then primitive reflexes will be usually absent. You lift the baby, do the moros, they'll just be like that. I always rely on two other reflexes which I use for prognostication as well. One of them is your suck reflex. So any baby, term baby, should be able to suck. If the suck is absent, you're in trouble. The next one I use is put the finger quite back, or you observe nurses doing the NG tube, then you will know whether this baby is having the gag reflex. These are two quite good higher motor functions. So it can also be helpful in prognosticating when you've started the cooling. So criteria A, condition of baby at birth. Criteria B, all about the clinical examination that you're going to follow using Sarnath criteria. Now, I put in Helix trial because in India, it's very, very hard. Hardly 10% of people do blood gases, that too in major places. Not many people will do cord blood gas, So therefore, we had to modify the criteria what we use in order to identify the suitability of these babies for cooling. So one of them was Helix trial, which was a multi-center trial. Our Bangalore hospital, which is the Institute of Child Health, was also one of the participants of this trial. What they did is they've taken the age as less than 6 hours. This anybody can say. Time of birth, age, anybody can say. Take birth weight into consideration, more than or equal to 1.8 at least. Okay. Now gestation, because if it is known, it is very well. If it is not known, then obviously you have to take birth weight into consideration. This is the reason I put the birth weight earlier. Need for continued resuscitation at 5 minutes of age, or the Apgar score of less than 6. If the babies are not born in hospital, anybody can tell you whether the baby cried or not. So this is the criteria also that can be used, right? Evidence of moderate or severe encephalopathy using modified Sarnath scoring. If these babies are in the PHC, if they don't know how to tell you the moderate Sarnath scoring, I have sometimes used technology Dr. Praveen Venkatgiri always tells me technology is the way forward. So we have used it, like for example, live video, and then seen the baby, ask them to perform few things, you know, and then assess. It's not absolutely brilliant. It's not absolutely gold standard, but is beneficial. It is adding more knowledge to your assessment. I am talking about these babies when people refer to us from various parts of the state and the neighboring states as well. So therefore, Helix trial, this is one of the things that I use as a criteria in order to decide, because we sometimes don't know gestation. We don't have blood gases in all the peripheral centers. And it is very hard for people to do the encephalopathy scoring. Very easy for them to understand is your seizures or the fits. That is why I say, take a video, send it to us. We can also collectively assess. So moving on, your baby satisfy the cooling criteria for A and B, start cooling. If you don't cool, refer to a cooling center. If the baby doesn't meet the criteria, continue standard intensive care if it is possible in your unit. I hope I'm clear until this point in time. So moving on. So total body cooling. How do we do this? See, there are two methods of doing it. One is using a servo control method. Dr. Dinakar initially was putting up slides from GenWorks and other people. You know, this is one of the cooling machines that we are using, Thicotherm. The other cooling machine what we use in our unit is, for example, Critical Mini. That is also helpful. It is one of the ones which can be used as a transport cooling machine as well. So it is a transport compatible cooling machine. So the machine is extremely easy to use. So if you look at it, it has got two monitoring things there. One is for your rectal monitor probe. One is for your surface monitor probe. This is the surface on the forehead. I hope I'm showing this with the arrow mark. And then there is this outlet for this where, for example, in Thicotherm, they use the ethyl alcohol. They used to use, I'm not sure whether they're using water now. Then in Critical, for example, we use just general distilled water to put it into the machine. So what happens is the machine, when it is switched on, it will ask you the date, time, and everything. You fill in everything, then the machine starts. Okay, you have a jacket here. This is a baby. You have a jacket. So the jacket has got pores all around where your water or the alcohol circulates through that and then keeps the baby in the cooling condition. Why I call it as servo controlled? Because the machine, once it starts and achieves the temperature, it maintains that temperature beautifully with just a little bit, 0.1 to 0.2 degrees up and down. So it will keep doing that and then maintains your temperature clearly at 33.5 degrees for 72 hours. So look at it. Start this and achieve the core temperature. What I mean by core temperature is the temperature of where the rectal probe is. The rectal temperature is called the core temperature. And maintain it at 33.5 degrees. You should start cooling within 6 hours of age. So when we get a referral from far off places, we sometimes ask them to start passive cooling, which means switch off the warmer, sometimes use cold material just around the baby, but not touching the baby, never touching the baby. Sometimes places like Bidari, Raichur, Gulbarga, we say use the AC, or you can use fan as well. So use all this method, but you can drop the temperature quite a lot. That is also detrimental. If you're doing passive cooling, you have to do only thinking that the active cooling people are coming to take your baby away. Only then, for the temporary period, you should do passive cooling. Cooling is done for 72 hours, and slowly the baby is rewarmed after 72 hours, and we generally take 8 to 12 hours to rewarm the baby. You can rewarm as slow as 0.2 degrees up to 0.5 degrees per hour. Especially important, if you're rewarming, a baby starts developing convulsions. We have seen this happening. Then what you do, don't rewarm very fast. Rewarm very, very, very slow. 0.1 degree also at that point in time. Slowly rewarm. Okay, that is one of the tips that I would give you. So there is an indigenously developed or manufactured cooling device. It's called the Mira Cradle. It works on the principle of phase changing material. So you have two phase changing material called FS21, FS29. What it does, the more this material is, it can become harder and solidify, or it can become liquid. So the more liquidified it is, the higher temperature it has got. The more solidified it is, lower temperature it has got. Sorry, I have not put another figure where it shows there is an indicator on that, the color indicator, where it says whether the FS21 or F29 is ready to. One of the prerequisites for this is you have to keep both this FS21 and FS29 inside the refrigerator. That is a prerequisite for this. If you don't, then it is not ready for use. So it's very, very simple. It has got a cradle here, you know, and then you can place your FS29 mattress here. Then you have a conduction mattress. On top of this, there is a baby, right? So it's as simple as that. You need to use a rectal probe anyway, thermometer. That is connected to not a special device, but to your multipara monitor. A lot of multipara monitors have got rectal probe, you know, rectal temperature monitoring inbuilt in that. Otherwise, you need to buy a new one, and also you need to buy rectal probes. So here, what happens? Baby is placed on the mirror cradle. So temperature is set between 32.2 to 33.8. This is on your multipara monitor, and then, you know, rectal probe is inserted, and you start the cooling. What are the things that can happen? Baby might not cool very fast, in which case, instead of using only, you should also use FS21 and then start cooling. Once you acquire the desired temperature, you remove FS29 and put it in the fridge. Clear? Then, what is the evidence behind it? This is this product is developed by you know, CMC Vellore. I was told, along with you know, IIT people, and then Dr. Niranjan Thomas is one of the pioneers for that. For this, along with that, there are a lot of other people, stalwarts, who were involved in developing this, you know, very cheaper alternative to the servo control machine. And it has shown that it was done study across 11 centers with 103 babies. It was well published, and then the conclusion was it is safe to be used and it is feasible in India. And also, you know, temperature, when you look at the temperature, it is comparable to servo controlled machine or the mode. So either you use servo control or you use phase changing material, which is Mira cradle. What you do is you start induction phase of starting the cooling, where you reduce the body temperature from 37 to 33.5 degrees. Then you maintain what is called as the maintenance phase for 3 days. Then you start slowly rewarming, which is called the rewarming phase. So this is how you start, you maintain, and you end your therapeutic hypothermia. I hope I'm clear so far. So now, I think Dr. Rajat will touch upon more detail about the other therapies and the monitoring. I just wanted a little flow. That's why I'll just quickly go through this. Supportive therapies. Coming to the ventilation. So I will always say, guys, make sure your unit is level 3, level 2A plus, level 2B plus at least, you know, when you start cooling. The reason is majority of these babies are very, very sick, and these babies would need a lot of intensive care, not just the cooling. Cooling is very easy part, but looking after these babies is extremely difficult, right? And majority of these babies, especially moderate to severe, bordering that, will need some sort of a ventilation support. I would say if these babies have meconium aspiration, they might even need gentilation or gentle ventilation. The way we provide this is maybe using high frequency oscillation ventilation. Otherwise, there is increased incidence of pneumothoraces as well. Aim towards normal CO2 and pH towards alkalosis, or at least towards normal. CO2 washout may happen. You know why? Because these babies are extremely metabolically acidotic. You know, the base excess is -16, -20, lactate will be 8, 10, 12. So the compensatory mechanism is they have to breathe like a train. They just keep breathing faster, and then they keep letting the CO2 out. And CO2 washout of, you know, if your CO2 is less than 30, majority of your brain blood supply will be lost. Less than 25, almost no blood supply happens to the brain. If you're interested, you put your, you know, the probe on the head and use the Dopplers. You will see for the babies with less than 25, 20 CO2, almost flicker of blood will be going through. It's very important. Make sure that CO2 washout doesn't happen. In some circumstances, we have taken over ventilation of these babies and sedated these babies so that the breathing is under control. So you can also do that. Consider sedation paralysis, as I said, especially important paralysis if you have an associated, pulmonary hypertension. Especially this is common with meconium aspiration. Coming to the supportive therapy with circulation, avoid boluses. Yeah, please don't keep giving boluses. Your base excess will not be treated by volume unless you have a volume loss with severe abruption or placenta previa or the baby has bled quite a bit. There is no need for many boluses. One bolus is more than enough, maximum 2 bolus. Don't give more than that because it will hamper the cerebral edema. So this is what we do. As well as that, don't don't avoid hypocarbia or hypercarbia. Both can worsen the cerebral edema. We tend to restrict fluid to 40 ml per kg because the babies also tend to have liver damage, kidney damage also. So if the baby has got the kidney damage, it's usually acute tubular necrosis. Then what happens? The kidney is not functioning. Therefore, whatever fluid you keep giving, the baby is getting bloated up, and then it hampers your ventilation also. Then what happens? It can result in worsening of your kidney failure. Therefore, restrict the volume to 40 ml per kg. Adequate blood pressure is very, very important because the pulmonary hypertension can be very much associated with total body cooling because hypothermia is one of the risk factors for this. Also, whenever you have hypoxic ischemic encephalopathy, that alone itself can cause pulmonary hypertension. So beware of this. And second day, third day, fourth day, when your kidney starts improving, you will end up having massive diuresis. Then at that point in time, make sure that you start giving more volume. Also, all of us use aminoglycosides, whether it is netilmycin, gentamicin, amikacin. If you don't have good urine output, your kidney will pack off. Therefore, it is extremely important for you to not give the second dose until and unless you confirm it with good creatinine function, or whether at least you have more than 1 ml per kg per kg per hour of urine output. Some of the practical tips: awareness regarding sentinel events should be there. Inform the cooling center ASAP and seek advice. Take informed consent before passive cooling also in your center, and we take consent for active cooling also. Secure UVC, UP, or a PICC line, because once a baby is cooled, Brahma should come to secure the peripheral line for these babies. It's extremely hard. So secure central line. And also a lot of these babies might need inotropic support. Very important to get the central line. Always consider the multi-organ involvement, and the servo-controlled cooling should be complemented by a fantastic NICU. Very quickly, complications of cooling. We don't experience too much of complications of cooling. Prashant, I think I'll take another 10 minutes, please. Very quickly, okay? We tend to see sinus bradycardia as one of the most common complication. Your heart rate may be anywhere between 70 to 100. Don't worry. I will be worried if your temperature is good, 33.5, but you're tachycardic, because tachycardia in these circumstances tells us the baby is extremely septic. So be careful about that. The second complication we normally see is thrombocytopenia. That will be, very, very significant. It can go down to 70, 60. Also, your sepsis might be contributing towards it. I don't want to do more about these complications. These are the two that you should be worried about. Investigations, I think, Rajat will go through the investigation part of it. I know I am rushing because I know I'm short of time. So when you look at the total body cooling, it is already a standard of care in the West. It's just a matter of time. I know one of the obstetrician out of Bangalore has been sued for 1.5 CR because she did not refer this baby for cooling, right? So the case is still in the court. But this happened 3 years ago. Imagine now, and that baby developed cerebral palsy. That is the fight going on. So imagine, please make sure that if you don't cool, you at least discuss with the parents. Clear-cut documentation should be there. Current protocols require cooling to begin less than 6 hours. Cooling as early as possible is ideal. I'll tell you why. Passive cooling helps before the help arrives, because you start cooling as early as possible. Even 1 hour, half an hour is very helpful. There is always this conundrum of mild hypoxic encephalopathy. Why? When I looked at the Sarnath staging for your criteria, they did not even include mild in the criteria. They did not even define that as one of the criteria. So let us look at it. When they did look at all the mild babies, and they published, Walsh et al. Published in the Human Development 2018. When they looked at the MRI of these babies that was not cooled, they saw almost 20 to 40% having injury in the brain, and lots had watershed injuries, which suggests that these could have been prevented. Then you look at it. Sarnath himself has suggested this. Basically, the HIE, the encephalopathy, is very, very dynamic. It is not a static thing. You had an insult, it keeps progressing, it keeps getting worse and worse and worse. Stage 1 can become stage 2, stage 2 can become stage 3. Therefore, you have a baby, you resuscitated, you thought it doesn't fit the criteria, don't go home and sleep, or don't go to another place, start vaccinating. Kindly come back, have somebody else looking at the baby. Repeated clinical neurological examination is very important. We have seen a lot of times, mild, we think the baby is with the mother or in the NICU, 8 to 10 hours of age, starts fitting. So we'll be kicking ourselves at that point in time. So keep re-examining these babies. And when I looked at some of the evidences, the PRIME study, we had the international cohort had suggested 16% with the disability. There was a systematic review as well done, which suggested 22% of abnormal outcome. And mild HIE does not uniformly give you good outcomes. Please, as we go about learning more and more, I am 100% sure we will start cooling more and more, because medico-legally also it will become important. What is mild HIE or grade 1 HIE at one point in time may become grade 2 or grade 3 because it's a progressive insult. Then some of the gray areas I wanted to touch very quickly. What about the hypothermia? The recruitment is already started. NIHCD is doing the trial. What about the effect of depth and the duration of the trial? Say, for example, 32 degrees. Why not 32 degrees? Why only 33.5? Why not cool for 120 hours? Why only 72 hours? Why can't we have delayed cooling between 6 and 24 hours? These are some of the things that I'll just quickly in 2 minutes address. Optimizing the cooling is what we say. Dr. Sita Shankaran published in 2014. So when they looked at it, they had divided it into 4 treatment groups. One is regular cooling, set criteria, 33.5, 3.5 days. 3 days cooling, half day rewarming. They divided it into 3 other groups. One is 120 hours versus standard, and called it as longer. One is 32 degrees, which is deeper, versus 33.5. One is 120 hours, which is longer. Normally it is 72. Now why not 120? Add on to that deeper cooling also. So they did that. So look at this. The lowermost one is the deepest and the longest. That had very much decreased survival in this group. So therefore, it is not advocated at this point in time. I don't know whether if we add any adjunct, Rajat might give an idea into that. So whether we add any adjunct, it might change. I'm not sure. So moving on, the delayed cooling criteria. See, as I said, what is this delayed? It is 6 to 24 hours. The selection for cooling criteria should be the same, but they looked at 6 to 24 hours. Like I told you, baby was okay. It progressed 8 hours, 10 hours, it started having convulsions. What do you do? Those sort of analysis was based on 2 different types. One is a frequentist analysis, which is based on the number game. Then is a Bayesian analysis, which based on the interpretation of that. So I don't want to bore you into any of this. What is the conclusion of that? Result should not delay the effort to recognize early HIE and start hypothermia within 6 hours. Please be careful. Reassessment, reassessment, and reassessment. Next, they looked at the hypothermia initiated at 6 to 24 hours. May have benefit, but there is uncertainty to its long-term effectiveness. That doesn't mean you sit quiet for 24 hours. Oh, it is also there. It can also show benefit. Don't sit there. Try and use as much as possible. Like amplitude EEG is one of the brilliant ones, which our Pradeep is going to talk. So this is an animal study done on the mice, 2006. Gunn and Thorson reported in the neuro treatment. So the first one is the sham cooled, which means they've not cooled it. Then we have a very early cooling. This is a mice model at 90 minutes. A delayed, which they took it as 5.5 hours. We still have that within a 6 hours limit. Post seizures, they took it as 8.5 hours. You look at this, the first graph, this x-axis represents various brain areas: parasagittal cortex, temporal lobe, striatum, then the dentate gyrus, and the hippocampus. So the smallest one is the gray one, which is light gray one, which is when they started cooling less than 80, 90 minutes of age. What happened? They had a fantastic outcome wherein on the y-axis, if you look at it, it suggests the neuronal loss score. The neuronal loss is very, very less if you start cooling extremely early in all the areas, as opposed to if you see the black one, the neuronal loss is as good as not cooling in all the areas. So please make a decision. Don't play with it right now. Don't wait. Make a decision, because the brain doesn't wait for anyone. And this was replicated in the human study by Dennis Azapadi when they looked at their own segregated outcomes and published in 2010. The Toby trial had 105 infants, luckily, which were recruited less than 4 hours. They showed significant amount of betterment in death as well as the disability. So, 2 minutes, we will go through 3 or 4 cases very quickly. People should say yes or no, or raise your hands if you're cooling. Don't raise if you're not cooling. So this is a baby boy born locally, did not cry immediately after birth, no cry. Continued resuscitation for 5 minutes. Up gas, 1, 3, and 1 and 5 minutes. Baby started ventilated. Cord pH, we had a cord gas done. pH of 6.7, CO2 55, base excess minus 19, bicarb 14. Cool or not cool? People are raising hands. Come on, quickly. This should be very easy after this, lecture. Yeah, it's quickly going up. The numbers of participants raising the hands quickly going up. So I think this baby satisfying all the criteria for cooling and should be cooled. Definitely yes. Quickly moving on to the second one. Again, another baby born locally. This is a baby girl. Noticed to have abruption. Did not cry immediately after birth. Continued need for resuscitation. Apgars 1, 3, 1 and 5 minutes. Ventilated but extubated soon because the baby started breathing. The blood gas which was done, cord pH 7.1, CO2 65, base excess minus 12, bicarb 18. Do you cool or not cool?
Option scared is not.
Raising hands. People still wants to cool. See, according to the NIH CD criteria, base excess is fitting here, but pH is still 7.1, which doesn't strictly fit into the criteria. This probably gets into the situation of mild HIE or mild to moderate. This is where I have not given you much information about the encephalopathy. Look for encephalopathy. Look for seizures. Look for aphistotonic posting. Look for decerebrate rigidity. Look for all your reflexes very, very, very carefully. And as I told you, it is a very dynamic situation. This is at birth. What happens after some time, after 1 hour, after 2 hours, keep looking for it. And this baby, I personally would keep looking at it. Any sign that I find, I will cool this baby. So I'm sitting on the fence on this baby. Baby referred from 180 kilometers. Baby girl, gestation not known, birth weight 2.4 kg. Now the birth weight, from the Helix trial you can select because we don't know the gestation. Meconium aspiration, did not cry after birth. Continued resuscitation 15 minutes. Ventilated, no gas available. Had very poor tone, weak cry. Cool or not to cool? Raise hands please. Cool, not to cool. This is again one of the easiest of the ones. Here, the difference is we don't have a blood gas. We don't have a gestation, but we have birth weight to look at that, and we have other things, continued need for resuscitation, and your encephalopathy, which is very poor tone and weak cry. I would cool, and I think most of you are saying the same. Another baby, 320 kilometers, referred. Baby with maternal abruption, did not cry after birth. Continued need for resuscitation, 10 minutes. Apgars 1, 5, and 1, 4, and 5 at 1, 5, and 10 minutes respectively. Ventilated, pH 6.9, base excess minus 19. Cool or not too cool? Yes, I think this is again very easy for me. Continued need for resuscitation. Cool this baby. Baby also had very poor tone. One more thing I wanted to say here. In all these examples, what I suggested, there is something called HIE or neonatal encephalopathy. 2 slides, I go through that. The majority of these babies have meconium aspiration syndrome and PPHN. And these babies need transport. A lot of these babies are very, very sick. Keep that in mind. So also think there is HIE is only one cause of your neonatal encephalopathy. There are many causes of neonatal encephalopathy. See here, hemorrhages can be there, strokes can be there, inborn errors of metabolism. All of these can behave in exactly the same way. So therefore, ultimate diagnosis what you give is neonatal encephalopathy. A major chunk of that is your HIE. Don't forget this. So some of the clues, the no event or normal at the time of delivery. Think about genetic errors of metabolism. Seizures immediately after the birth, SSRI in the mother, or some of the inborn errors of metabolisms. Seizures don't stop within 4 days. Genetic epilepsy, inborn errors of metabolism. Very difficult to extubate. Neuromuscular disorder. We had a baby, we extubated, reintubated, extubated, reintubated. Went back, did the MRI of the baby, including the spine. Then we had a transaction of the level of the spinal cord at C2 and C3. So very important to look for the clues. So in summary, I think Prashant is getting anxious and I am also. HIE or neonatal encephalopathy is very common in India. Therapeutic hypothermia is beneficial and safe. Therapeutic hypothermia is a standard of care in the West. Will catch up very, very soon. Don't ignore mild encephalopathy. Please keep looking for it. I have started cooling mild encephalopathy. People who use more and more cooling will start doing more and more. Cool early, as I said, even 10 minutes of age. If you know it is absolute HIE, switch off the warmer during resuscitation. But for you to do that, you need more experience. But you still have less than 6 hours to decide. Beware of other causes of neonatal encephalopathy. And HIE is an emergency, guys, because there is a limited window period, therapeutic window period for you. I would like to thank NNF for such a wonderful opportunity for us to showcase what we guys are doing in this part of the world in India. India also is doing brilliant in these aspects. And I hope I've been clear in certain aspects and also in highlighting certain points where the gray areas are present. Hopefully, if you have not started cooling, start cooling. India needs more and more to that. With that, I would like to dedicate this talk again to Vishnu Rasaya and finish. Thank you very much.
Yeah, thank you, Dr. Pratap. You took 1 hour 15 minutes. So I will move on to the next topic. Pradeep sir?
Yeah, I'm ready.
Can you stop sharing, Pratap?
Yes.
Prashant, you are not audible.
Can you stop sharing the slides? Stop sharing your slides. Yeah. Over to you, sir.
Thank you, Prashant. I'm audible now?
Yeah.
Okay. So I think I will not waste much time in beginning my talk. And just a quick thanks to Prashant and NNF Karnataka for organizing this wonderful seminar. So my talk is going to be exclusively on talking about the role of Aaeg in HIE and probably add 1 or 2 slides on which other conditions can we use the HIE as such. I do bring greetings from our Ramaya Medical College. What I'm going to do in next, hopefully not taking a longer time, more than 20 minutes, is just tell you quickly about what's Aaeg and the role of Aaeg in asphyxia. More specifically, I think probably I'm going to concentrate more on the role of Aaeg in asphyxia. And third, quickly, as I said, few conditions where you might extend your use of Aaeg. Is Aaeg very new, something which we have seen now? No, it was well devised in 1950, but initially this Aaeg was meant for adults, especially in cardiac anesthesia, where they were used for post-cardiac anesthesia or post-arrest state or post-MIs to look at their brain. So it wasn't really devised for the newborn use. So it was well in 1960s when Aaeg was used for adults. But eventually people started looking at why can't we use the monitoring for the newborn babies also. And I think the whole importance of AEG gained only when we started cooling babies, because people needed something very objective to look at the encephalopathy. We have all been through this Sanat and Stanat, and we know how subjective it is, and depends on the year of resident you have and the kind of experience or the kind of training the residents have received. The Sanat and Sarat can be very, very subjective. So people were looking at something very objective to say whether this baby, does he have encephalopathy or no? Because once that question is answered, and then I think we can call up Pratap to say, okay, Pratap, this baby has encephalopathy, can you start cooling? So if you ask me, do we need an AEG and NICU? So I would say definitely yes, because AEG, is my video seen, Prashant?
Yeah, it's seen,
Yeah,
sir.
yeah, sure. So if you ask me, do we need an AEG and NICU? I would say definitely yes. Why do we need it? We have a pulse oximeter to look at the saturations. We have the ECG to look at the heart rate. We have a respiration. We have a temperature thing. But if you ask me, do we have anything objectively to monitor the brain? The answer is we do not have. And do we need one? Definitely yes, because as Dr. Pratap said, encephalopathy is a dynamic process. You need something to be continuously monitored. Even if I come and do 8th hourly, 12th hourly, 6th hourly, you're still missing out the 6 hours or 8 hours in between. Is there an objective way at looking at the baby's brain in a continuous fashion? I think the answer is yes, we need. And do we have an equipment to do that? Yes, we have a simple amplitude integrated EEG. What is amplitude integrated EEG? If I have to just put it in one single line, it is a simplified EEG, conventional EEG or reduced EEG. What do we do in this amplitude integrated EEGs as compared to 22 lead conventional EEG? What we are trying to do is we are sort of summating all the activity into simple waveform. So what we does, I'm not going into the technical details of it, but what we need to understand is there are the filters which will sort of filter out the waveforms which are less than 2 hertz or more than 15 hertz. They sort of amplify the lower filters, sort of compress the higher end filters, and they make it into a simple band form. So what it is trying to do is summating the whole activity, the 22 lead conventional EEG, into simple band. That is all the amplitude integrated is doing, and it does at a speed of about 6 centimeters per hour. So I'm just making things very, very simple, not going into too much of the technical details. Is it very difficult to teach interpretation of amplitude integrated EEG? Absolutely no. I can put it in next 3 slides. I can tell you how we interpret the amplitude integrated EEG. But is it very simple and easy to teach a conventional 22 lead EEG? My answer is no, it's not very, very easy. We need a complete training to read a 22 lead EEG. I'm sure all of us have an experience when people come, the patient brings you the report of a 22 lead EEG, and you'll be struggling to see where to start and where to end because you have no idea how to read that, and you'll be searching for that final page where the report is written. This is why the conventional EEG is very, very difficult. Now we'll just be putting 3 slides just to show you what is normal, what is moderate, and what is severe. This slide that you are seeing is a normal EEG pattern. So what you are seeing here, I hope the pointer is working, that you see a normal sleep-wake cycle. When the baby is sleeping, the waves are a little broad. When the baby is awake, the waves are narrow. So what you're seeing is a narrow, broad, narrow, broad. I want you to understand this. This is a normal EEG pattern with a normal sleep-wake pattern, or what we say SVC cycles. The upper margin is more than 10 volts and the lower margin is more than 5 volts. If you look at moderate encephalopathy, you have lost that sleep-wake cycle. You have a broad band where this is more than 10 and this is less than 5, and you'll have a loss of sleep-wake cycle. So if you see this EEG, this means this baby has moderate encephalopathy. Now what you see here is a complete suppression of the background activity with occasional bursts where the upper and lower both are less than -5 millivolts, and this is severely abnormal EEG. So if you have this or this pattern, this baby is very well warrant for cooling. This is one slide which is showing you the Scheser activity. If you look at it, I have just put this. So this is a raw EEG and this is a amplitude integrated EEG. So suddenly if both lower and upper margin rise above, then that is probably a seizure activity. You see a couple of them here. And if you see the simultaneous raw EEG, I'll tell you why this is important to look at simultaneous. You are repeatedly seeing, you're seeing a repeated sharp spike pattern. And this, along with a sudden rise in the lower and upper waveform, will tell you this is a seizure activity on amplitude integrated EEG. So it just takes about 5 minutes for me to tell you what is normal, what is moderate, what is severe, and what is seizure. It is as simple and as easy as it is. Where do we use the amplitude integrated EEG? Predominantly, our use of amplitude integrated EEG is in perinatal asphyxia. And second is, yes, a couple of other conditions where I will tell you at the last, but predominantly the complete use of amplitude integrity comes in perinatal asphyxia. What do we do with EEG in perinatal asphyxia? One, we make use of the amplitude integrated EEG to select the babies for therapeutic intervention. Second, we also use AEG to prognosticate. Third, we use AEG to detect and appropriately use our anti-epileptic drugs in managing a baby who's having HI and neonatal seizures, knowing very well 50% of the babies with neonatal seizures are going to be due to perinatal asphyxia. So we have 3 jobs of amplitude integrated EEG: to select the right babies to cool, to help the baby to be prognosticated and the parents to be informed more objectively, rather I would say. And third is to help us to continuously monitor the seizure activity and use our anti-epileptics appropriately. How do we use the AEG for selecting criteria? If you look at it, somehow the Americans are not very fond of this amplitude integrated EEG, and they were not really convinced. There were 2 major trials, CoolCap and the Toby, and Americans keep debating, say that age is not a very good criteria to be used. But to me, in a country like ours, where I might have a residence, I may not have a qualified person at the time when the baby has come to assess and tell me exactly. If I have a first-year resident on duty and if I ask me how the baby is, he might just say baby is sleeping. Now, he may not be able to tell me whether the baby is depressed, baby is having HI, baby is not having HI. So it becomes very, very difficult for me to decide if I'm not at the site to decide whether this baby needs cooling. So AEG will give me a simple objective way of assessing. As I told you, if the baby is just arrived, coming back to one of Pratap's scenario, babies just come, you have fainted study about what has happened, the babies just come, it's already 4 hours, you don't have too much time to talk and do everything, just put the AEG, minimum 20 to 30 minutes of a strip, and if it shows moderate to severe, you start cooling the baby. Yes, with the history of your sentinel events and the history of the perinatal events that have led to the perinatal asphyxia. So to me, it is an objective way of assessing. I know you can choose the babies based on your neurological examination, but for me, AEG is an objective way of assessing neonatal encephalopathy, especially in centers where you do not have a qualified person sitting at the time when the baby has come to you and you need to quickly decide whether we need to cool this baby or not. Off late in my unit, it's a very common practice. Baby has come, they record 20 minutes, they send me a snapshot of WhatsApp and say, so this is a baby, this is a history, this is the age, what do you want me to do? It becomes very easy for me to say cool or don't cool. So I will just touch upon this particular study where there was an argument, as I told, Americans, especially Shankar and all, and there were studies where say, no, age is not, it should not be the sole criteria. We are not saying sole. What we are trying to look at it, can we combine your neurological examination and abnormal AEG quickly? If you look at it, individually, they didn't have a very good positive or negative predictive value, but combined, both of them has an excellent positive and predictive value and negative predictive value. So what it means is clinical examination along with AEG may be more ideal to select the babies for neuroprotective therapies than relying on amplitude integrated or the clinical examination alone. I hope I made that message very, very clear that AEG is a very objective way of doing it. Is it mandatory? No, it is not mandatory. Can it be an add-on to clinical examination where you might be fluttering with the way you have assessed? Yes, AEG and clinical examination together can be a fantastic way of having a very objective criteria to decide whether this baby needs cooling or not. And that's my key message on selecting the babies for cooling. The second important question I'm going to answer is, can AEG predict the outcome of the baby. The baby has come 6 hours, 8 hours. The parents are asking you a simple question. Doc, tell me whether this baby is going to do well. Otherwise, I don't want to waste my money. Or you tell me exactly what is going to happen to my baby. So you need, again, something very objective way of saying, see, look, this baby might do. I might say, oh, 30% babies do well. He's not interested in knowing out of 100 babies, how many babies do well. He just wants to know, will my baby do well in long run or will my baby not do well? And probably a lot of things decide, the continuing care also might decide on that statement. Prognosis of babies with HI amplitude integrated, I'm just trying to put it as pre-cooling period and cooling period. Pre-cooling period, whenever they looked at, I'm just summarizing a systematic meta-analysis that was done, and they said that of all the studies, amplitude integrated did predict, have a very good sensitivity and specificity in predicting the long-term neurological outcome. Another systematic review which compared the AEG with the conventional, amplitude integrated with conventional, both at 6 hours, 24 hours, 72 hours, there was a very good sensitivity and specificity as compared to EEG when we want to prognosis. This was a pre-cooling era. And even when we looked at our own experience in the pre-cooling phase, whenever the babies had a normal tracing for the first 24 hours of life, we had to just look at the mortality and 3 months outcome. This was a very short 50 baby study. When the babies had a normal AEG by 24 hours, they all did fantastic. None of them were abnormal, no mortality. When 24 hours, there was a moderately abnormal tracing. Almost 80% of them were not normal at 3 months and about 4% had mortality. Babies who had severe encephalopathy at the 24 hours, they did uniformly bad. Either they were neurologically abnormal or they succumbed. And this is almost like a pre-cooling. We got AEG much before we started cooling. So this was almost the phase when there was not much cooling done. And we felt that a 24-hour, if the AEG is normal, it had a good sensitivity and specificity to say this baby is going to do well. But I completely agree. This is a very, very short outcome. We don't have a follow-up of over 18 months. But what it means is we did have a very good objective way of saying by 24 hours, if the AEG was normal, they did very well. By 24 hours, the AEG was looking flat. We said this baby is probably not going to do well. AEG in a phase or in an era of cooling, they said that 3 to 6 hours, maybe the AEG does not predict the outcome very well. So that was the studies which the retrospectively looked at, both the Toby trial and Sita Shankar et al. When they looked at the NICHD and cool cap, they did feel that maybe AEG at 3 to 6 hours does not really tell you, well, everything will be good or bad with this baby. But what is very, very important, I think, is reversal of AEG, of return of sleep-wake cycle by 36 to 48 hours in a baby who's cooling has got an excellent prognosis. So what it boils down to tell you is, I will just show you a small video later on, but what it tells you is if your baby's AEG has come back normal, though it was moderate or severe to begin with, but it did come back to normal by the end of 36, latest by 48 hours, this babies did fantastically well. If the baby never had a return of sleep-wake cycle or the baby never returned to normal, it continues to be severe encephalopathy even at the end of 48 to 72 hours, I think you can start telling the parent this baby may not do very well. I'm not going to the trials, but I'm just summarizing the whole thing in two simple statements that AEG at 3 to 6 hours may not tell you much in a cooling baby, but a reversal of AEG back to normal or return of sleep-wake cycle by 36 to 48 hours has got a good prognosis. Just run through a video just to show you what do we mean by return of sleep-wake cycle. I don't know if this video is going to play. Yeah, I think, I don't know, the video is not playing. It's okay. I just wanted to show you, this is a video where this baby started off with moderate encephalopathy, but by the end of 24 hours, this baby started having a sleep-wake cycle, the return of sleep-wake cycle, which is a very fantastic way. So we could tell the parents by the end of 24 hours, see the AEGs come back to normal. I think this baby is going to do fairly well. I'm not going to say that everything is going to be fine, but the chances this baby is going to do well is definitely high. So as far as the prognostication is concerned, my message is very, very clear. Amplitude integrated can assess the severity and predict the likely neurodevelopmental outcome following asphyxia as early as by 36 to 48 hours. So this you can do by looking at the continuous AEG pattern in the first 72 hours. The third role of AEG is in neonatal seizures. All of us who are working in NICU will agree clinical recognition of neonatal seizure is very, very difficult. And especially if you have a very busy unit and you have multiple babies with asphyxia, it's very, very easy to miss. You might have to train your postgraduates, you might have to train your fellows or nurses, but still there is a good chance that you could miss neonatal seizures, or sometimes you might be alarmed by even the flicks and some movements which may not be exactly seizures. The statement that I've highlighted is there is a feature of electroclinical dissociation, and this is a cardinal feature of neonatal seizures. Why this is very, very important in this context when I'm talking about is once you give anticonvulsant to the baby, these babies will stop showing you motor manifestations and will only start showing you electrical activity. Now, this you cannot pick up if you do not have a continuous conventional all amplitude integrated EEG. And the incidence of this could be as high anywhere between about 60% to 80% in some studies. So what it means is if I do not have a way of looking at the amplitude or looking at the electrical activity, I could be missing out on almost 60 to 80% of seizures that could be happening, and the baby could be very well lying very quiet without showing you any motor manifestation. So continuous video EEG was definitely a gold standard, but how many of us have a continuous conventional video EEG? It's a challenge. We do not have it. Personally, I do not never have it. I just know there are Western centers we had it. None of us have a continuous PD. So how do we pick up this electroclinical dissociation? So if you ask me, then which is the better modality, amplitude integrated or conventional EEG? Conventional EEG, no doubt, is a gold standard. Video monitoring with conventional EEG is definitely the gold standard because you're seeing the movements and you're seeing the electrical activity, nothing like that. But the problem is you do not have it in all the places. You do not have the expertise. You cannot keep the 22 leads onto the baby continuously there. You need an expertise to read that conventional EEG. And yes, you need a whole sort of, a video monitoring facilities where somebody is continuously recording that and you come back and review for the 24 hours. So practically at this point, a conventional video EEG monitoring is ideal, but not easily available. What is an alternative option that we have? Amplitude integrated gives you a real-time detection of electrographic seizures. It provides the opportunity to treat when it happens. So you are continuously looking at it and when it happens. Doing an interictal conventional EEG again is useless. The baby has come today scissoring, and tomorrow if I get a 22 lead conventional EEG for 20 minutes, it's not going to help me. I need something continuously, and I need to load the anticonvulsant when it's required, add on the anticonvulsants when it's required. Advantage of EEG over conventional is we don't require a very specialized type for the interpretation. I showed you 3 slides. I could teach you how to interpret EEG. Very, very easy because you just need to put 2 leads as compared to a 22 lead conventional EEG. Can it help me to manage my anti-epileptic? I need not keep loading anticonvulsants unnecessarily, or I may not be in a position where I've just left the clinical seizures to be left alone. I'm just hoping to show you this particular video, which shows you how a electroclinical dissociation happens. Prashant, can you help me with this? Yeah, I hope this video is seen.
Yeah, it's seen. It's okay.
Okay, sorry.
Just click on the image, go back. Minimize and play the video, sir.
Yeah, I think I just did that mistake. Yeah, I'll do that. Yeah. So if I can just show you, I just want everybody to appreciate this is a seizure activity that is happening continuously. Now, this is almost like a status, but I just want you to look at the baby. This baby is under cooling. And if you look at it, there is absolutely no motor manifestation in this baby. So if I did not have an EEG, if I was just looking at the baby clinically, I would have probably left it alone. And I would have said, yes, this baby is doing very well. But if you look at it, this baby is continuously scissoring. This is what is typically called as an electroclinical dissociation. So what do we do with this information? Do I treat now? The issue is, should I treat all this electrical activity, or should I wait for the baby to throw a fit in a motor manifestation treat? I think earlier we were told as postgraduate that you treat only if the baby is scissoring, don't worry about the electrical. But now I think there are enough animal studies and there are recent studies to say probably this electrical seizures add to the neuronal damage. So it's a good idea to treat these electrical activities also. And when you treat both clinical and electrical seizures, I think the outcome is much more good. I'm not going to the details of that study, but to summarize, now evidence is moving more and more towards saying that we need to treat these electrical activities also. Just a quick, what is the limitation of using EEG for neonatal seizures? Yes, the cost of equipment, it costed us about 14 to 16 lakhs. I don't know what's the current cost now, but that costed us so high, bit expensive. But the major limitation you need to understand is seizures which last less than 20 to 30 seconds can be missed on EEG. Now that's a major limitation. If you have a seizures which lasted only 10, 12 seconds, the electrical activity cannot be picked up. That's the major limitation of AEG. You may not be exactly be able to tell you from which part of the brain it is arising because you are getting summary of all the brain activities. So even if it's coming right, left, back, it just shows you as seizure activity. But I think as a clinician, it doesn't really bother from where it's coming as long as I'm treating the seizures. You may not be able to tell you what kind of seizures classification and all because it just shows you a seizure activity. Now, these are the limitations of using amplitude integrated EEG in a child when you're managing neonatal seizures. Artifacts were the common reason where people say, no, there are a lot of artifacts and you cannot differentiate an artifact from a seizures. But the reason I showed you that particular photo is that when you have a seizure with a raw EEG, you can very well pick up. So the key message here is amplitude integrate is very useful tool for continuous monitoring of seizures, and it provides us a good information. The only limitation you need to understand is you might miss those brief seizures. Prashant, I'm just coming to the last slide. So the other conditions where you want to use the amplitude integrated EEGs, seizures due to other causes. It's not necessarily only the perinatal aspects that you're talking about. You could use this for even neonatal seizure. Day 5, the baby comes with seizures. You don't know what it is. Or many times the common scenario is the parents pick up the baby and come, my baby had a movement. We are not too sure whether it's seizure or not. You're not very sure because right now the baby looks good. Admit, put him on continuous AEG for 24 hours. If there are seizure activity, it will be picked up. Metabolic encephalopathy, now people are looking at using amplitude integrated to look at encephalopathy. It just tells you there is encephalopathy, but it also helps you to differentiate type of encephalopathy. If you have ammonia disorders, it might show you moderate encephalopathy to severe encephalopathy. Paroxysmal disorder might just show seizures without showing encephalopathy. So now people are trying to see whether we can use AEG to monitor baby with inborn error metabolism. And I think this is going to be a next way to look at or you extend the use of amplitude integrated. A child had an arrest, a child had a severe acute life-threatening event. I want to know what's happening to the baby's brain after that. You could put the baby 24 hours up to 72 hours on AEG and look at the brain. So it's not necessarily encephalopathy, is not always asphyxia. There could be other causes. Can I use it for bilirubin encephalopathy? Yes. Can I use it for a baby with neuroinfection to monitor the brain? Yes. So important thing is to understand AEG has a major role in HI, but it also helps you to just pick up babies, use the AEG for babies with seizures, baby with any form of encephalopathy, whether post-hypoxic, metabolic encephalopathy, infections or bilirubin, so on. So I think AEG now has extended its use. So I think my key messages for today's talk is it's definitely a very objective clinical way of monitoring the cortical function bedside. So like a heart rate, like a respiration, I have a very objective way which I can come back next day, review through, scroll through, and exactly know what has happened to the baby's brain in the last 24 hours, which will not happen with my repeated clinical examinations. AEG is useful in assessing the severity. It does tell me whether the baby has encephalopathy or not. It helps me to prognosticate or tell me whether this baby is going to do well by the end of 36 to 48 hours. It helps me to pick up and treat all kinds of seizures. Continuous AEG will definitely help us to use our drugs more judiciously, either to use too much of drugs or not treat those electrical. I think this can only happen if you have a continuous AEG. Thank you. And this is one of the babies which was schooled with amplitude integrated EEG, doing fantastic at the end of 1.5 years now. So thank you, Prashant. I hope I could keep up the time that was allotted to me. And if there are any questions, I would probably take it at the end of this talk.
You were bang on time, sir.
Thank you.
Yeah, just stop sharing this. Yeah,
I'll do that. So I've stopped sharing.
Yes, sir. Yeah. Fantastic. I mean, this has been a real thrilling session all throughout. So we'll move on to the next topic. Rajat?
Yeah, can I share the slide?
Please start sharing. Yes.
It says it's still disabled.
No. You are
As always, precise and crisp. Vishwas.
Can I try again?
Yeah. 1 second. Just try again.
Oh.
I think you were co-host. You exited from co-host. 1 second.
Okay. I think
Rajat, does it come now?
yes.
Please tell.
So good evening, everyone. Sharing. So you can see the screen?
Yes.
Yeah. Good evening, everyone. So continuing after two very interesting talks. So I'm going to touch upon the monitoring and supportive aspects of a baby we are looking after and we are cooling, and what adjunctive therapies are out there. So yeah, just give me 1 second. So when always you get given a topic in a conference or a seminar to talk, I try to decipher what is it exactly that they're asking me to do. And the way I read the topic that Prashant sent me across is during cooling, how do I ensure good outcome? So I've decided to cool as was decided by criteria and assessment. And apart from cooling, are there any other measures which actually matter for the outcome? So it might be the current treatment strategies, or it might be something that is going to come up in the future. So during cooling, how to ensure good outcome, I wanted to ask myself a few more questions. So I wanted to ask, what are my aims of therapeutic hypothermia? And what are my aims about with regards to managing HIE as such? What effect does HIE itself and also cooling has on the physiology of the baby? What are the comorbidities that are associated with HIE? What to monitor in respect to the organ that we're trying to protect, and what to monitor with respect to other organs? And with cooling, what other neuroprotective mechanisms or measures that I need to take? And with brain, what other organs to support? All simple questions, but I thought I'll frame these ones for myself. And with regards to adjunctive therapy, I wanted to answer why cooling may not be enough on its own. What are the new biological targets that scientists are discovering in an injured neonatal brain? What therapy is still at the lab bench stage and what is arriving at the bedside for us to use? So if you look at this, a very simple statistic is that mild HIE has a normal outcome, moderate has fairly, this is in the cooling era, about 60-70% of them do well. But the most worrying thing is the one on the right side, which is most of the severe ones either die or they are left with significant disability. So this is the thing. So what are the outcomes that actually we want to look at in terms of getting this baby better? So the first and foremost thing is you want the baby to survive and leave the unit. You might want better seizure control. You might want that the baby should stop being encephalopathic, start feeding and go home. Long term, what we're looking at is not only this baby has survived, but this baby has survived fairly intact in terms of developmental assessments and functionality at around 18 months to 2 years. And neonatologists are now also interested what happens at school age. So school age 8 to 10 years, and all our graduates are becoming adults. Curiously enough, as we grow old, our patients also are becoming younger and contributing to the society, older I meant. So some of these measures are easy to quantify and some of them are quite difficult. So this is the conundrum. So in terms of, we've all looked at the brain injury cascade and the pathway of hypoxic ischemic insult. The first insult is where you become severely energy deficient. So, and then there is a latent period, and then a secondary cascade of energy failure starts, and then the tertiary phase of reparative and plasticity ensues. So the first one is an energy failure. The second one we have caught on as the window of opportunity to start doing something, specifically cooling. The third phase is, which lasts for hours, we have tried to cool the baby. And the fourth one is what we are left with after we have got the baby to survive and have finished the cooling treatment. So there are definitive metabolic parameters. So it is to do with energy metabolism of the brain cells. It is to do with the excitatory cascade or excitatory amino acids that the brain uses. It is to do with the free radical damage that are seen after reperfusion. And an injured brain is an inflamed brain as well, not only short term, but also long term. And then there are brain specific proteins that people have started looking at to actually look at what is happening in the brain as the baby is going through the first few days of HIE. And then we have started looking at endogenous metabolites and chemicals which actually contribute or mitigate brain injury. Obviously, for you and me at the bedside, we cannot do anything about any of these things as of now. So short term, what is hitting the brain, very simplistically put for a practicing neonatologist, is we have secondary damage, we've understood that, and we have cooling specifically to target that. We know that there are definite things that insult the brain further, for example, hypoglycemia, seizure burden, and we know that the brain becomes a pressure passive circulation, especially in a newborn who is unwell. And there are lots of shifts in fluid and electrolyte balance in this unwell baby, which can exacerbate the cytotoxic edema that has happened. So just to touch upon a few of these things, and I will then arrive at a point as to what we monitor and why we should monitor. I think monitoring becomes very mechanical and almost, a tick box exercise unless you actually understand what you're, aiming to prevent. So when we look at brain injury, especially with respect to HIE, we know that if the baby was also hypoglycemic, the sequelae actually increases several folds. The second thing that actually now we understand that further damages the brain, injured brain, is the seizure burden. So it is no longer a chicken and egg kind of situation. We know that the encephalopathy per se starts off getting the baby to seize. So this is a baby who is seizing, who's being cooled. So this is something that you can easily pick up. But sometimes it is not so easy. So the cause becomes the effect, and the effect becomes the cause again for brain injury. So the more you seize, the more the brain gets injured. And we know that. So we know that any seizure is not good. So poor outcome if any seizure, 44. Early onset, if the seizures start early, it is worse. If the seizures are much more difficult to control, this is really bad. Okay. So if you have to remember, any seizure is bad. Earlier the seizure, the worse it is, and the difficult it is to control the seizure, the worse the outcome is. So it becomes very imperative when Dr. Pradeep said that we need to have a fail-safe way of looking at seizures and measuring the seizure burden, especially in a baby who's been drugged. Okay. The other thing that is quite useful is to have a reasonably replicable, objective way of scoring the baby's encephalopathy. So what I would suggest is that you follow one scoring system in your unit, which you can train your trainees, and then it is done fairly, regularly, and they're as objective as possible. Then we had a fantastic talk about amplitude integrated EEG. So this becomes a very, very important tool. Again, I will not stress the point, but very important to remember, if it is very severely abnormal in the first few hours, it's bad. Rapid recovery is good, and early return to sleep wave cycle, with which Dr. Pradeep mentioned, is a very good sign. So now we are realizing, as with everything else in medicine, if you add one parameter which you're monitoring and you actually look at another parameter, for example, amplitude integrated EEG with neurological examination, that gives you a little bit more benefit. So the units who have AEG can look at it. If you have a EEG, this is available in most multi-specialty hospitals and medical colleges. So this can also be done, even if it is not video EEG, if you had only 1 or 2 instances where you would do. So how it depends on how abnormal it is, how soon EEG has become abnormal, and how long does it stay abnormal? These are the questions to ask yourself. So if you were to have only one chance of doing 1 hour EEG, I would say you do it at 48 hours. So if anything stays abnormal at 48 hours, that baby you need to worry a little bit more. So if you're not very good at reading EEG and you're a bit like me, and you can just see that there is no seizure activity or no burst at all for a long time, you need to recognize that EEG as a bad one. So inter-burst interval is something that you need to look at. If it is more than 20, then it is not good. Okay. So what you need to do is, if IBI is more than 30 seconds, 100% it's going to be bad. More than 20 seconds is not good. So it is usually between 3 to 5 seconds. So brain should be an active, electrically active organ. So if there is a lot of quiescence in between the bursts, it is not good. Now coming to the important thing, why we need to know about whether seizure is happening or not is you need to treat it aggressively. So as Dr. Pradeep mentioned again, so a decade ago or 2 decades ago, we were like, oh, you don't need to treat all seizures that you look at. And we were typically told you wait for 3rd seizure within an hour to treat, which might hold good if you're not very certain that if it is a seizure or not. But if you have objective ways of looking at it, then you have to treat. I would treat any seizure if you have not started treating. So you follow your local guidelines, which is phenobarb, phenytoin, levetiracetam. So personal practice, because Prashant asked me to bring a bit of personal practice as well. Clinical seizures, I start treating. I do not wait till the 3rd seizure. Electrical, if I'm very certain what I'm looking at the CFAM machine or the EEG, I treat. First line, I've started using levetiracetam with good results. Second line, I use phenobarb or phenytoin, depending on the baby. Refractory seizures, a word of caution, a very, very difficult to control seizure. You need to investigate that baby. That baby may not have hypoxic ischemic insult secondary to perinatal asphyxia. Might be a brain malformation, might be a bleed, might be a stroke, might be other things as well. So very quickly, rounding up the neurological assessment and monitoring, a very useful bedside tool is ultrasound, and what is useful is MRI and MRS. So ultrasound actually is quite mandatory. You just need to confirm the brain you're trying to salvage is actually grossly normal. Then you look at a very important parameter of loss of autoregulation. So if your resistive index is high, or if your diastolic flow is actually reversed, those babies are not going to do well at all. And very, very early, if you start seeing very definite brightness in the basal ganglia, that is not good as well. So this is the advantage of bedside ultrasound. So you can see this is a gadget heavy kind of a scenario where the baby is being cooled, and the baby has to be meticulously monitored for your cooling to have the desired benefit. So so there are more machines than you can easily count within 5 to 10 seconds. And I also want to draw your attention to the amount of documentation and charting that needs to go on meticulously. So this is one of the sickest babies we will be looking after. These babies need to have lines and invasive monitoring. We usually monitor continuously with a amplitude integrated EEG, and we actually document cerebral blood flow periodically after admission. So when you're looking at MRI, as I gave you some tips about what to look for in an EEG as a neonatologist, when you send your babies for MRI, which you should do between 5 to 7 you need to ask your neuroradiologist to report on 2-3 things which are very, very important. Okay, otherwise everything will be lost in the jargon of the radiologist's report, and ultimately, please correlate clinically is all you will be left with. So 3 things you need to look at. You need to look at basal ganglia, you need to look at plic, and you need to look at cortex. So these slides might be quite difficult for people who are watching on handheld small devices. I'm just realizing that now, apologies for that. But these are all straight away taken from Walpay's latest edition. Please have a look at it. And it is like, it gives you a very, very beautiful decision-making tree and prognostication as far as MRI is concerned. In the interest of time and in keeping view that this is difficult to view, I'll move on. So basically, if your BGT is involved, then you're actually not going to do very well. Plic changes can be moderate to severe. Severe BGT changes are bad. So these three things you need to get out of the
Hello.
Okay. So we, as a routine, we also do MRS when we're sending for MRI, which is of a theoretical interest right now. One or two cases which I think I've been muted. Am I audible?
You're audible. Go ahead. Go ahead.
So, so MRS is quite useful in picking up several other things, several other metabolites in case you had a metabolic baby as well. But otherwise, you know, what I've mentioned on the slide holds good. These kind of ratios are very useful to kind of quantify MRI with MRS degree of this thing. So if I sum up neuromonitoring, I spent a little bit more time on this because I think you need to start thinking about, when you start thinking about cooling, you need to start thinking about ways of looking at the brain and looking at whether you're doing the things right or not. Neonatal encephalopathy scoring systems you can have it standardized in your unit. You can use a modified Sarnath, Thompson, whatever you're using, use it consistently. Ultrasound you can usually use. You should have some way of looking at the electrical activity at the brain, either continuously or at second day. MRI, MRS, I think probably should become standard of practice in most this thing. I am aware that there will be resource constraints and medical legal issues and other things. What might come in handy, and they've been telling us about these biomarkers for a long time, they have not come in, but some have, some are promising, and we'll see whether we can do. The other organs we need to look at. See, this still staying with the brain, this is a depiction of something being done to the baby. So this baby's blood pressure has fluctuated for 45 seconds in the blue, and the same is immediately reflected in the brain. So this is how poor a cerebral autoregulation is in a preterm or in an injured brain in a term baby. And all that was being done when this graph was recorded was a diaper change. So every small thing you do will actually reflect in the brain cerebral circulation. So quickly coming on to cardiovascular support, remember only one number, your heart rate needs to be around 100. When you've cooled the baby, your baby is allowed to be bradycardic, 90 to 110 is the range. So if you're having heart rate of more than 100, 110, 120, this baby is tachycardic. And you would deal with it in the way you would deal with a sick baby with tachycardia. It might be to do with pain, sedation, requirement, hypotension, sepsis, and the lot. And remember, CRT is gone out of the window. You cannot measure. You need to have invasive intraarterial continuous blood pressure monitoring. And also remember, urine output may not reflect cardiac output. So these babies might have renal shutdown and you cannot monitor that. Naturally, coming over to fluid and electrolytes, you remember the cerebral edema can be worsened with SIADH. There is a lot of setting, I mean, there is definite setting for SIADH to happen. There is renal shutdown possibly. So this is the reason to restrict to 40 ml per kg. Dr. Fatehpur had, I have not opened the chat window now so that I don't get distracted, but Dr. Fatehpur had asked, do we keep at 40 ml per kg? So we have just come up with 40 ml per kg. So you might have to go up to 40 to 60. And if at all you have then a baby who is passing urine and giving you a reasonably good indication of its fluid balance, you might want to tailor the fluid requirement to that, but avoiding cerebral edema. One very important thing is these babies can be hypoglycemic or maybe glucose intolerant, but do not deprive the baby of a good glucose load. So a lot of times I've seen that just because of a little bit of hyperglycemia, the sugar is switched off and you will push this baby into further catabolic state. So baseline, you need to establish a baseline. So we usually do not test electrolytes because we thought always that it would reflect maternal electrolyte status. But this is one situation where you have a sick baby, you need to know the baseline. You would not tend to feed the baby at all, but you might do colostrum painting and minimal enteral feed has been done in some centers. So you need to have a policy for that. But usually mother is separated from the baby and it all becomes a little bit difficult. So swiftly moving on, you just do not have any excuse for not having umbilical lines and invasive monitorings. The most experienced person comes in and puts the lines and disappears from the scene so that you can get on with other things. Gone back. So then you need to monitor these babies very closely. So recently, one of the babies we cooled about 6 months back, after recovery, the renal dysfunction had not recovered as much. And we were caught out, the baby's potassium had risen. The morning potassium was 5.2. And by noon, this baby had started showing all different types of arrhythmias and arrested and had to be revived. So you have to be very cautious about monitoring electrolytes and fluids and renal status, and you might have to do blood tests every 12 hours. Okay, so I won't repeat that: minimal handling, sedation, avoiding bolus, and all that stuff. Respiratory support, I get asked when I teach about cooling, should I ventilate? So you might need to ventilate because there is poor drive, or you have really drugged the baby to its eyeballs and the baby cannot breathe. The gases need to be warmed and humidified. Anything else in terms of ventilation? Ventilation should be according to your standard protocol. If at all you need to sedate or paralyze for whatever reason, you need to realize that the drugs can accumulate. This baby's metabolism has slowed down, and you need to monitor this baby's acid-base state balance and CO2 and oxygenation very well. So drop in CO2 is a potent vasoconstrictor, and it happens in matter of seconds. So if you have a baby whose CO2 has washed out, you're causing further cerebral ischemia to this baby, which is dangerous. So you need to monitor this very carefully. You might be in a tricky situation. Most of these babies are easy to ventilate, except when they're coming with a baggage of meconium aspiration, some amount of pulmonary hypertension, or sepsis, which is getting worse as the day passes. Blood parameters. So the sweet spot for a hematocrit is between 45 and 55 for good oxygen carrying capacity and for the circulation to be fluid. Most of the studies did show that clotting times can be prolonged, but none of our babies, at least in the Toby study, had any significant coagulopathy. 1 or 2 babies in India have encountered that if there is gram-negative sepsis, it becomes extremely difficult to manage. There was one such baby where we had thought about stopping cooling, but I think we initially supported with blood products and it resolved, and we probably continued. So FFP and blood product use should be according to your unit protocol. So should be your sepsis management. So the baseline blood tests should involve, at least in our country, a blood culture, infection markers, and as I've mentioned, electrolytes, calcium, magnesium, glucose. Lactate is a very, very useful thing to quantify what is happening. You expect the lactate to get worse and then start getting better. But if you have somebody's lactate sitting at 8, 10, 14, that baby is slowly dying, right? So there will be other organ injury, which will be reflected by your transaminases, creatinine going off, and coagulation should be monitored, I think, as a baseline and at least 24 to 36 hours later if there is no bleeding. So this kind of, I hope, puts it all together. What is very important is nursing care. So it is more important than in any other baby that you're looking after. Minimal handling. Position needs to be changed. Just because you're in a cooling jacket doesn't mean that you have to be lying in one position all along. You need to definitely avoid cold burns. So this is mostly seen in when people have used indigenous things like ice packs and saline bottles which have been kept in freezer and other things. The modern cooling blankets should not do this. And the one thing that we always forget is we have a grieving mother somewhere else, not in the ICU. So the mother is separated. You can do as much counseling as you can, but you remember the postnatal plasticity actually starts with mother bonding and all the other things that we need to do. Please involve mothers and let them start visiting, touching the baby and look at the baby and start expressing milks and things like that. That is a very important aspect of care of the baby. So monitoring, if I have to summarize, you need to have meticulousness in monitoring, and you need to have thresholds for each of your parameters so that the people on the ground escalate it for action. So cardiovascular monitoring, neurological monitoring, oxygenation, ventilation, fluid balance, hematology, other things, pain. So especially if you're kind of cooling a baby who is only mildly encephalopathic, this baby is a very uncomfortable baby. You might have to give a little bit of morphine or fentanyl. Skin and soft tissue also need to be looked at. So you have this brain which you're trying to cool, but what actually matters is what is outside the box in terms of infection, hemodynamics, normoglycemia, electrolyte, and so on and so forth. What is very, very important, I think previous speakers have also alluded to, is importance of counseling and buying in of the parents to commit to a treatment for 3.5 days and beyond, and having measures which are objective for yourself for prognostication, like EEG, Dopplers, and the neurological examination and other organ damage, is very, very important to keep on updating them realistically. So that kind of completes my supportive treatment and monitoring. Adjunctive therapies was a little bit hard to tailor for me because most of the knowledge is borrowed from listening to people who are actually involved in these kind of studies and reading up. So what I'm doing is distilling some of that information that I've gathered, and I will present it in a way that I thought would be useful for a practicing neonatologist. So before I move on, the AAP clinical statement is the standard of care, just so that we complete this, is standard neonatal resuscitation based on your NRP. Assessment of cooling should happen at birth, and cooling needs to begin within 6 hours. But we know that brain is time. There are studies now suggesting that if you start cooling within 3 hours, those babies might do well at 18 months. Diligent management of seizures, cardiorespiratory support, and fluid balance. This is what AAP has said. And babies who are looked after in units where there is MDT presence with all kind of technicians and subspecialists, not only during the acute phase, but also what becomes important in terms of therapy services, developmental pediatrician, early intervention is probably as important, if not more, when you have taken on to do some neuroprotection in a baby who is not going to make it in the first place. So why do we need anything more other than cooling? So we do this because in the 2 hours, I don't know how long we have taken now, 2 hours we have sat and spoken, about 1,000 babies have been born with significant birth asphyxia, a neonatal encephalopathy, and about 400 of them are going to die, right? So even in cooling era, what is become very difficult to budge is the devastating outcome in the severely encephalopathic baby, and whether we can tweak the outcome for moderately encephalopathic babies who we have cooled and given some kind of a benefit with terms of cooling. So what is beyond cooling? So one thing we'll look at it is hypothermia, and during therapeutic hypothermia, what do I add on? There is a lot of information that is coming now. Can you tailor the treatment based on biomarkers? And we saw a small therapeutic window between 0 hour and 6 hours. So now I'm going to tell you that a lot of windows and doors are opening up beyond those 6 hours, well into the weeks and months of the baby's life. And very interestingly, especially for low and middle income countries like us, some of these adjunctive therapies can be mainstay therapies on their own because of their affordability and ease of administration. And very importantly, people have started thinking back. So suppose if we were monitoring a lady in pregnancy and we knew this fetus was distressed, maybe a sinusoidal pattern or severe bradycardia or an abruption or something, can neuroprotection begin prenatally? We have been doing it in preterm babies in terms of steroids and magnesium sulfate. So there are some candidates that the mother can be disease, and then it might have some benefit. And as I said, neuroprotection has to extend beyond the neonatal period. So from the time the baby goes out of the neonatal period. So there is this concept of what we call as tertiary damage now. So again, a small cartoon, but I don't know whether everyone without a big screen will be able to see. The tertiary injury is all about an upregulation of a lot of inflammatory cells, lot of oligodendrocytes which are not matured into providing myelination, lot of increase in excitatory amino acids, and gliosis, which is scarring. So in terms of people who are not in basic science like you and me, most of you, so these are the things which do not allow neurons to axons to myelinate. Synapses will not be formed. There'll be a lot of abnormality in neurotransmission, more towards excitatory, and that gets damaged. And gliosis means scarring. So more and more dead brain, right? So in terms of biomarkers, a very brief one, because we cannot cover everything. So there are biomarkers which are directly as a result of neurons being injured, biomarkers which suggest that there is inflammation going on around the neurons. And then there are biomarkers which look at metabolites which are formed. So you can see these are the biomarkers. None of this is available at bedside. So I don't think we need to spend precious moments that we have going through those things, but you need to be aware. So what people have started looking at is whether they can test these biomarkers. These can be tested in blood. Some of them can be tested non-invasively in urine and in CSF. Whether certain babies can be targeted for more neuroprotection. They've also started doing MRS by 18-24 hours. If they see certain markers, so same biomarkers will be reflected as abnormal peaks and patterns in the spectroscopy. So those babies can be targeted. So these are all things that are happening. It's very important that we know that, because something very simple might come out of those studies and we might be using it in the future. So as I said, a lot of opportunities have opened up for neural rescue. So antenatally, then at resuscitation, during the hypothermia, this thing, and then beyond hypothermia. So again, so there are a lot of mechanisms like excitotoxicity, oxidative stress, blood-brain barrier disruption, apoptosis. See, what you need to remember is the primary injury of HIE is actually a homicide, right? So the cells just die because they're killed. And the secondary damage which starts is suicide. So there are apoptosis that is happening. And the tertiary damage is, I think, what we will have post-lockdown lifting up of lockdown. So we'll only realize how dysregulated or not things are going to be. So I think we are now very safe in a lockdown period where we are being cooled. And once everything opens up and you're asked to go and fend for yourself, what is going to happen is anyone's guess. So there is a lot of opportunity. There is a lot of inflammation, angiogenesis, neurogenesis, and a lot of other things happening, which are targets for treatment. So pre-birth, 4 candidates have come up. Allopurinol, which you know is a scavenger of free radicals. Azithromycin apparently has neuroprotection. So who knew that? And melatonin, we all know that it is got neuroprotective. So these are the things that the mother can be given. So there are trials going on. So at resuscitation, can we do anything different apart from following NRP? So we know that stem cells might come as a add-on treatment to babies with brain damage. So why not give a stem cell transfusion to the babies at birth? So they have looked at having intact cord resuscitation even in babies who are severely asphyxiated. So doing the resuscitation even as the placental circulation is on, you might be thinking of milking the cord as well. Then vasopressin has been proven in rat models and other models as a neuroprotective agent by its own right. So people have started thinking, can we use vasopressin instead of using adrenaline in our resuscitation algorithm if we knew this baby's brain was potentially damaged? So neonatal period is, studded with candidates. So the most important things I'll be discussing, so I'll not bore you to death. So a few headline grabbers. So just like Arnab Goswami picks up 3 things that he needs to debate and shout on, so I'll be picking up 2 or 3 things. So the erythropoietin and its analogs, stem cells, and a very interesting thing called as RIPC, cannabinoids rather, not cannabis, melatonin, I had to spell check this and write monocyanoganglioside. I've typed it, so I might as well read it. So these are chemicals which are found in basal ganglia in lesser quantity in injured brain. So then they thought, why don't we give this? And xenon and argon, which I'll mention briefly. Allopurinol, which I've mentioned, N-acetylcysteine and allopurinol are scavengers of free radicals. Magnesium sulfate, has multiple effects on neural systems. Topiramate has a neuroprotective action apart from its anti-epileptic action, azithromycin. And lastly, people thought, why not do a potpourri of things? Why not add one with the other and see whether things work? So a lot of these studies are going on. So beyond neonatal period, what do we have? Beyond neonatal period, what they found is mainly to do with repair, with inflammation, and things that we don't easily comprehend, what is called as epigenetics. So if there is methylation of certain ends of certain DNA structures, so things are zipped up or zipped open, so that the reparative process itself takes a different turn. So they are harnessing this and seeing that if they can give certain inhibitors to see if demethylation can be promoted and then somehow trick the brain to repair itself. They've also looked at modulating the brain's innate immune system, the lymphocyte activation system, by injecting microRNA. So most of these are animal studies. Then stem cells. And then there are something called as exosomes. So stem cells are foreign, but what they've done is whatever is within the stem cell they've extracted. These are small bits of RNA, I think. They go and do what the stem cell was meant to do. And stem cells are not only progenitor cells, but they're trophic cells to everything that is around them. Then amphakines are also closely related to that. And then growth factors, a candidate one is insulin-like growth factors. So much to take in. So I wanted to see if I can find a table where what is undergoing clinical trials, that is being tried on human subjects, and what is in preclinical work. So clinical trials is all these things: erythropoietin, melatonin, stem cells, which are doing what endogenously happen, exogenously the other things that I have tabulated. Very interesting preclinical work is going on with trypsin, argon, azithromycin, and other things. So very quickly, 3 or 4 things, and I'll wind up my talk. Erythropoietin has a variety of action, and in an asphyxiated baby, it is endogenously generated because of hypoxia. Okay, inflammatory, anti-apoptosis, and proliferation. All these mechanisms can be potentiated. Okay, so very simply put, in short term, in an asphyxiated baby, erythropoietin saves cells. So it prevents cells from dying in the first few days. So by reducing inflammation, etc., etc. In the long term, what has been found, it is reparative. So it promotes erythropoiesis, promotes angiogenesis, brings in more oxygen to the brain, brings in more oligodendrocytes, which are very important to myelinate your neurons. So people have got terribly excited about erythropoietin. They've started looking at erythropoietin alone, whether you use massive doses of erythropoietin, combine it with therapeutic hypothermia, combine with growth factor. Japanese are studying magnesium sulfate with erythropoietin. A few studies, acronyms are put there. If you want, you can look it up. The HEAL study is the biggest one. It is a high dose erythropoietin study, which is recruiting in many centers. And then they're studying different mechanism of neuroprotection, like allopurinol with this thing, and albino trial is going on in the European continent. So that is about erythropoietin and its combination. Xenon has been looked at. Xenon is a noble gas which inhibits the NMDA signaling. So xenon is very expensive, and one of the studies, Toby Z looked at it, did not find any additional benefit. So they're looking at argon, which is its country cousin and doesn't cost much. So then very briefly about stem cells, because stem cells itself can be a talk, and admittedly, none of us are experts on it. what they've looked at is there are several barriers. So most of the studies which have looked at is the safety of giving stem cells, and the numbers are very small, human trials. What they've looked at is if you give stem cells, most of them are sequestered in organs like liver, and they may not reach where they need to reach. If they do reach, then they're being proven to actually work in a very helpful way. So this is an animal subjects cross section, I think rodent. So what they've started doing is to provide intranasally. So intranasally, and that homes in. So you know that olfactory nerve actually comes in and then it can neurotrophically pick up. Another 2-3 minutes I should finish, Prashant. Yeah. So there is something called as remote ischemic preconditioning, where we are tricking the brain. So what happens in ischemia is you've already had ischemic damage in the brain, and certain actually useful things got produced in the body, but that ischemia has stopped, right? So what they're doing is they're non-lethally making a limb of the animal or the subject ischemic. The skeletal muscles in response to that ischemia starts producing things which go and work in the brain in a very reparative fashion. So this is remote ischemic preconditioning. So these are the things that actually, if it is proven well, we might be very good at doing in our centers. You know, tie a glove around the baby's wrist and wait for a few hours and remove it and things like that. Topiramate is quite promising in terms of safety, but when they looked at whether it actually mattered in terms of developmental quotient, it was not very promising. I will end with these few slides. A very cute little paper has been written as a systematic review and hidden away and published in a vague journal called Frontiers in Pharmacology. So I had to look it up, and somehow I found it was gem of a paper because it has included 15 RCTs looking at all the additional therapies apart from this thing and distilled the information that might be useful for us. So 2-3 slides from this paper. So what they've looked at is whole body cooling, selective head cooling, erythropoietin, magnesium sulfate, and kind of cooling with xenon. So what they found in terms of mortality is only cooling actually helped. Other things did not actually make more babies survive. What erythropoietin is magically doing is leaving less babies disabled, especially their motor capacity. So I've just put it selectively. It's a forest graph. You know, if the dot is more towards the left, then it benefits you. Erythropoietin definitely has a salutary effect on reducing motor defects, especially cerebral palsy. It is also good in terms of reducing seizure burden. So that is what we need to remember. And severe forms of neuromotor delay are better. This probably is almost impossible to read, but I would refer you to the paper. So it has included 15 RCTs, more than 2,000 babies, and looked at it. What it summarizes is, what evidence do we have? So in terms of, they've looked at it in a very interesting way. Suppose you just did whole body cooling. How many babies will be prevented from, extra babies will be prevented if they did not have cooling from having, protected from having cerebral palsy. So for cooling, for example, 180 babies extra per 1,000 babies will not have cerebral palsy. So the certainty of evidence for cooling alone improves survival is there. For head cooling alone, I think it's very American thing. It is also there. For magnesium sulfate, the certainty of evidence is low and it's possibly has limited effect. Erythropoietin, as far as survival is concerned, has limited effects in HIE. Whole body cooling with xenon again has very, very low certainty of benefit and is probably not indicated. So just moving on to the next slide. So in terms of, we're not just looking at mortality in HIE studies, we're looking at mortality or neurodevelopmental delay at 18 months. When we look at it again, cooling comes up top of the class, but very interestingly, erythropoietin is coming in at 18 months. So if you looked at the same measure, 296 babies per 1,000 additionally will be saved from having significant this thing. So erythropoietin is something that we are watching very, very closely. Okay, so quickly coming to take home points. So therapeutic hypothermia, I've just put in as a question mark, but should become standard of care. And I think Helix is here for us to try and answer whether there is anything that we need to be cautious in developing countries. Full monitoring and organ support should be the standard way of cooling. Neuro monitoring, imaging, multidisciplinary follow-up, and early intervention is probably as important as picking up a baby and cooling him or her and getting her to survive. And there is a very interesting expansion in our understanding of brain injuries itself, and they're coming up with newer targets for remediation of brain injury. And amongst the emerging treatment candidates, erythropoietin is the closest and the brightest star on our horizon. So I just want to say that and leave you with this, which I always say, and holds good for any unit. The whole is always greater than the sum of the parts. So I think we need to start doing more and more. I thank my team at the place I work, and these are my details. Anyway, I'm on WhatsApp in the same group. Any questions that are burning, I can take it up. And if at all there is any time, Prashant will direct questions to me kindly at the end of the session after Dr. Bidari has given his talk. Thank you very much.
Thank you, Dr. Rajat. So we are moving on to, after knowing the science, let us come to the practical aspect. So here we have Dr. Bidari sir. He is one of the pioneer in India to have used the total body cooling machine with amplitude EEG as well. He is one of the first in Karnataka to have cooled the baby. So he's going to speak about his experience of how it all started and how many babies he has cooled and what is his personal experience with his institution. Over to you, sir.
You're able to hear me, Prashant?
Yes, sir. Yes, sir. Yes, sir.
So, want to share our institutional experience with the therapeutic hypothermia. As you all know, the hypoxic encephalopathy still remains to be severe condition despite many advances in fetal and neonatal medicine. HIE is very much common in resource limited countries. Prevention of HIE is critical because CNS insult is irreversible. Global incidence of HIE is found to be 3 per 1,000 live birth, but what we see in areas almost 20% of our admissions are secondary to asphyxia related hypoxia. I need not just brief this one of pathology. Hypoxemia will induce into brain hypoxia and ischemia, depleting ATP, energy failure, primary cell death, reperfusion injury, secondary energy failure, secondary cell death, and hypoencephalopathy. So again, the severe pathology, which has been in detail, it is dealt by Dr. Pratap. So I'll skip these complications, as you know. Respiratory, mainly encephalopathy, abnormal hemoglobin signs, seizures, respiratory failure, persistent pulmonary hypertension, myocardial dysfunction, metabolic hypoglycemia, and other organ dysfunction. Here, what I want to tell is that we found good many babies had myocardial dysfunction. One should have a bedside echo round the clock in the NICU, and other thing is you should treat the pulmonary hypertension aggressively, and this comes to one of the leading cause of mortality for this HI. Therapeutic hypothermia, but these are all drugs used in animals, and now apart from hypothermia, just now you heard from Rajat regarding the usefulness of erythropoietin. I need not elaborate on that. It was in 2012 when I had about more than 400 admissions because of asphyxia It so happened that one of my nephew is working in as a neuroradiologist in USA, Florida. I just asked him what you are doing. He said he's doing in the MRI, neonatal MRI, and I came in contact with Dr. Mike Weiss, who is a neonatologist. He was surprised to know the incidence or prevalence of asphyxia in my area. So I went to USA, and Dr. Mike Weiss, you can see his certificate. This is endorsement that I have. Treatment of hypothermia. I was with him for 1 month and came to know about how they treat hypothermia, and even he helped me to get the hypothermia critical machine at a very reasonable cost. In fact, I bought it from Israel. I think I bought it for very concessional price. He helped me a lot. These are for neonatologist, and in the beginning, Dr. Sandeep Girbadarappa, who had just now come from UK, he has done a lot of experience regarding hypothermia. And Dr. Mike Weiss, these two people helped me before my neonatologist, Dr. Lakshmi or Sidhu, joined me. And we used to Skype with Mike Weiss, and Sandeep Girbadarappa used to come once in a week, and I used to Skype. To Skype, we used to get the advice, guidance from Dr. Sandeep and Dr. Mike Weiss. And we started with not only critical machine, we were the first one to start along with the safe monitoring only in 2014. This helped us a lot in diagnosis, inclusion, progression, prognostication, recognition, treatment of subclinical seizures. And it's very simple, even as you heard from Pradeep, even my staff just used to tell me, sir, this baby is getting seizures. Sir, this baby is improving. This is a brief outlook of incidence of hyperuricemia encephalopathy 2012 to 2000. Total HI cases 1835, total admissions 9,295. Here is maximum HI is 497. This is the one which made me to think seriously about doing something about to the babies of this area. Minimum is 140 case in 2018. Number of babies schooled till date, total admitted 1905, cooled 1201. You can see the trend of encephalopathy. After 2012, some of the prevalence has come down. It was 242, 232, 167. Now it is falling about 140 to 150 cases per year. Total number of babies schooled 201. Babies completed full course schooling 147. Abruptly terminated school 54. Death during the course 20. You can see the graph 201, 147, interrupted 54, and death 20. Criteria followed in the hospital: inclusion criteria, physical examination, history of asphyxia, prolonged resuscitation, duration less than 6 hours, active seizures, PS less than 7.1, base is more than 16, easy, moderate to severe encephalopathy. Exclusion criteria, congenital anomalies, coronary bleeds, severe infections, coagulopathy, intracranial bleeds. Problems encountered while selection, and maybe it will be so much of large number, why you have coded only to about 200. Duration from referral to point to hospital, lack of card details, cooperation of attender, in some cases not available, doctor shopping and roaming for second and third opinion by the time they reach our institute, early onset sepsis, timely referral due to limited ambulance services, untrained assisted home deliveries and no PS visits, doubtful aseptic precautions during transport. One of the point I would like to highlight is quite good number of babies which are improving, we lost them because of sepsis. So taking care, prevention of sepsis at the time of delivery is a very important point I want to elaborate. So we should give some attention for this. Definitely we can, the progress would be much better if early sepsis is not there, the babies which we are cooling. Investigation done routine CPKMB, electrolyte, blood urea, serum creatinine, blood sugar. Then coagulopathy, investigation for platelet count, APGT, INR, hemoglobin, total count, differential count, platelet net. Then SGOT, SGPT, EEG, continuous monitoring, bedside echo, daily and SOS, cleanliness. This one thing that bedside echo is very important for two things. One is good number of babies had myocardial dysfunction. And another thing is early recognition of pulmonary hypertension. As we go through the future, this one, pulmonary hypertension is one of the leading cause of, in our series, leading cause of mortality in the babies. Induction as early as within 6 hours, target temperature 33.5 to 34, maintain core temperature 33.5 to 34, control shivering, maintain hemodynamics. Rewarming over 6 hours. And of course, Pratap has told in detail about how it should be warmed and how the rewarming should be done. Treatment modalities, airway hood box, nasal pumps, CPAP, HFNC, ventilation, circulation, first line inotropomin, second line ethyl dopamine, maintain fluid, day 1 10, day 3 electrolyte P 10%, DNS target, GR 4 to 6 mg per minute. Antibiotic ampicillin amikacin if sepsis screen is positive as per unit protocol. If sepsis screen positive as per unit protocol, and we have a backtrack facilities in our institute, wherein we come to know within 24 hours the organisms grow. Anticonvulsant, as you know, phenobarbital, 1220, levetiracetam, pyridoxine, midazolam, and topiramate vary occasionally. Nowadays, we are using almost levetiracetam as the first line of treatment for convulsions. Bedside echo, cranial ultrasound on day 1. One of the first institutes in North Karnataka having point of care echo, screening echo once in 24 hours, cranial ultrasound, MRI brain, 10 to 14 days. Here, MRI brain, since we don't have more 3 Tesla, this one, we are not able to, our issue is not included in this HELIX trial. Cause of termination of cooling, septicemia, clinical bleeding, that is coagulopathy, pulmonary hemorrhage in 24 babies, that is 44% of the who had mortality. Refractory EPHN, 14 babies, that is 25%, 0.9. Intracranial bleed, 7 babies. Attendance personal causes, 9 babies, that is 16.6. Outcome, improve 147, that's 73%, death 10%, DAMA, that's 16.9%. Cause of mortality, septicemia, DSE, 13 babies. See, septicemia, if the proper care is taken at the time of delivery, you can definitely prevent some of the deaths. Severe PPHN, 4 babies, 20%, pulmonary hemorrhage, 15%. Short-term outcome, severe to moderate 80, moderate to mild 37, persistently severe 30. These 30 babies who are persistently severe, even at the time of discharge, these babies had 50% of babies we lost the follow-up. That's one of our problem. Though we have started early intervention center, Dr. Ravi Kumar, pediatric neurologist from Athreya, GMI, and Dr. Sundaresh, child physiotherapist, Dr. Anjali, Dr. Purushottam. This forms a team of early intervention center. It is started as soon as they started early in the NICU only, then it is followed up by our early intervention center, and once in a month, Dr. Ravi Kumar and Dr. Sundaresh give the guidance for further treatment. The early intervention center is established 3 years back in memory of my late brother Subhash Bidari Memorial Child Development Center. Our problems, long distance of referring units, lack of awareness and importance of cooling and referral units, crackery, difficulty in getting blood and blood products, sepsis, cost issues. Of course, we have not charged anything for cooling, and initially in the first 2, 3, 4 when we went for the wrapper also, we didn't charge. but we used to charge only for our NICU stay and ventilation. We didn't charge anything for the cooling. In spite of that, the people could not afford even the NICU stay. Then 50% of babies with severe HI do not turn for follow-up. This is a self-function monitor. This is a critical unit. Now we have 2 critical units right now. This is the 100 baby. You can see Dr. Sidhu Charki, Dr. Lakshmi, and my team. Now Dr. Srishal Girganti has joined me. This is a 200 baby. This baby with HI had a severe pulmonary hypertension. You can see our cardiologist also. We have in-house cardiologist. Take-home message: universalizing therapeutic hypothermia as a standard of care for HI stage 2 or 3. Involvement of government bodies to take intensive training and introduction of hypothermia in government setups. Timely neonatal transport. Institutionalization of deliveries and safe nursing practices. Senior practitioner to take lead in promoting awareness regarding hypothermia in peripheral referral units. Collaboration between the government and private bodies to reduce burden of HI in the society. Thank you. Every dark cloud has a silver lining. One more thing as a senior pediatrician, what I would like to tell is that we should encourage the neonatologist for this hypothermia, providing them equipments and as well as give them a free hand. You encourage them. That's what I did. The neonatolist, Dr. Lakshmi, Dr. Sidhu, now Sister Gadganti. So apart from whatever facility they wanted, I provided them, I encouraged them, and whenever they wanted my guidance, I guided them. I thank my neonatologist and my entire NICU team for whole body cooling. Probably I am first in Kannada. Maybe you should, the people should tell whether it is which CFM monitor critical cooling, hypothermia, which CFM monitor, whether it's first in Karnataka or South India, I don't know, but I am sure that it's first in Karnataka because the incidence was very high. I did something to help the people of this area. Thank you. Thank you, Prashant. Thank you, Dinkar.
Thank you, sir. Thank you for keeping up the time. And sir, Dr. Dinakar, sir.
Sir.
Yes, sir.
Yes,
Hello.
sir. Yes, sir.
Hello.
Kotreshi, sir. Yes,
hello,
sir.
hello, sir. Dr. Bidari, I am hats up to your work on the rural area and keeping the update of all the newborn activities. And very thankful for the newborn care you have taken so much. And I appreciate your involvement and courage also. And excellent talk on the hypothermic features. What is the stage you have to put? And I learned lots of people have been not able to pay the amount also. So that time also you have taken much care. Really nice of you, sir. Thank you very much. Thank you.
Dr. Bidari, I'm Dr. So, I think you have done a wonderful job in North Karnataka, whole of Karnataka, and probably South India. I don't think anybody has a correct number of babies. I don't think in one. Hats off to you and commitment and congratulations and well done. I think you should publish this as a study in some reputed journal.
Yes, Kishore, we'll try to do it.
Dr. Dinakar, sir.
Yes, sir. Can I ask the questions if you don't
Yeah,
mind?
please go ahead,
In
sir.
10 minutes?
Please go ahead and please moderate, sir. I would request you.
Okay, it is cutting. It is cutting. No, everybody is there. Okay. Hello. Please, can you mute everybody? Only speaker and Dr. Dinkar. Please, Dr. Prashant. Hello. Can everybody listen? Yeah. Contraindications for therapeutic hypothermia. Before you start therapeutic hypothermia, is there any contraindication? So Dr. Pratap Chandra, Chris, fast.
The absolute contraindication. Can you hear me? The absolute contraindication would be severe congenital malformation or any other dysmorphic weakness, or you see any chromosomal abnormalities. Other than that, there is no absolute contraindication. There are people who asked whether the cooling needs to be stopped in between. Again, I would say these are all relative contraindication. Your coagulopathy should be treated really well. Your pulmonary hypertension, you can go as much as to inhale nitric oxide to treat it. So sepsis, obviously, you need to use.
Dr. Pratap, only before therapeutic hypothermia, because there are a lot of questions, my dear, already 8 o'clock.
No, I thought I covered that. Yeah.
The other one, there is a baby with there is a baby. Once again to Dr. Pratap. There is once again a baby tracheoesophageal fistula. Unfortunately, baby had a birth asphyxia at the time of putting the nasogastric tube. They noted baby is having tracheoesophageal fistula. Do you think this baby is a very precious? Do you think this baby should be cooled or not?
First of all, I would say this is very, very unlucky baby. This is very, very unlucky baby to have two significant, problems at the time of the birth. If I say tracheoesophageal fistula, is it treatable or not treatable? Right now, we have a baby. We are easily treating that baby with surgery and all that. So, in these circumstances, if the baby is alive with vegetative state in the mind, or which we could have helped by doing therapeutic hypothermia, why not? But this baby should be in the right place of mind. And also we should allow the parents to take a very good decision based on all the facts that we give them. So we have to involve the parents in the decision making. But in my view, it can undergo cooling as well as surgery with TEF once the cooling is finished.
Yeah. Dr. Pratap Chandra is telling the same thing. Other person has asked the same thing. Transposition of great arteries diagnosed antenatally. Same thing as Dr. Pratap Chandra told. Parents have to be counseled, then to be taken, but you can treat AGA also, because it can be treated. Here the problem is different, because all the congenital malformations, there is no, you cannot do that. The second thing to Dr. Pratap Chandra, when you will stop therapeutic hypothermia, in between when you started, Chris, criteria.
We have done almost more than 100 cooling. Not just here, but in other hospitals and in UK as well. There was no situation wherein we had to stop the cooling. Apart from a couple of situations where the baby had severe coagulopathy, where it was not able to be stopped at all, in spite of giving FFP, cryoprecipitate, vitamin K, and all that. Number two is, if the baby dies, obviously, you'll have to stop it. So other than that, the third indication is, with amplitude EEG or EEG, if the baby's outcome is extremely bad, you've treated it for 24 hours, 48 hours, and you look at the baby, it's completely moribund and comatose. Then you have a decision with another colleague consultant who's happy to treat babies like this. Along with that, take parental consent, then stop it. So these are some of the areas where I would say mostly it is relative contraindication. It depends on your unit. Yes, sir.
So Dr. Pratap Chandra, what he's telling us, there are 8 questions on the same thing for the 8 people who has asked. Will you stop the therapeutic hypothermia in between? Yes. Dr. Pratap Chandra was explaining very good. Number 1 is, if there is a severe coagulopathy, if the thrombocytopenia less than 50,000 with bleeding, or if the already brain is almost dead. 1, 2, 3. And one more thing, if the PPHN is going, he told very clearly, if it is even with 100% oxygen, if the SpO2 is not maintaining, PaO2 is not maintaining, that could be the time you can even think of stopping. So there is one is severe cardiac problem, another is the brain problem, another 2 is a coagulopathy. Then, so Dr. Pratap Chandra, one more question to you. Fluid restriction, why particular number is formed of 40 ml? From where it came from? Dr. Pratap.
This came from anecdotal evidence where in UK when we were practicing, majority of the units were going for 40. There is no absolute evidence for this. Number 2, the majority of these babies, they would have given a lot of fluid boluses. Number 3, majority of these babies will also have acute kidney injury, where if you keep giving a lot of fluid boluses, it will keep bloating up. And therefore you restrict your fluid, also to protect your brain from cerebral edema. Then what you do, intensive care is not one-time decision and 3 days you leave it. It is not that. You have to keep reassessing the babies, make sure the urine output is good. If the urine output keeps going up, or if the AKI is improving and the baby is getting into diuretic phase, then obviously you need to start increasing your fluid. It is not written in stone that it has to be only 40, but we start at 40 and then looking at the baby's response, we go up.
Yeah. So Dr. Pratap Chandra is telling very clearly, it is not written in the stone. That means the particular number is nowhere it is there. Only assess the baby, what is the condition why this baby has developed hypoxia, then decide. Very good. So Dr. Pratap Chandra, one more question. Are you ready?
Yes, sir.
Yes. So I know that birth asphyxia will cause hyperglycemia because of the reasons we know. At the same time, if you will induce a therapeutic hypothermia, that will also induce us the hyperglycemia. We know that hyperglycemia more than 200 milligram is having bad neurological prognosis, at the same time death and infection, many things. How you are going to treat it, sir? Dr. Pratap.
Absolutely. This has not been one of the major issues that we have seen. Okay, a lot of times, as you said, the more than 200, 150, 300, if it is going up, it can be detrimental, but most of the reasons it is because of the stress response what the body is giving, right? Along with that, we know SIDH is another stress response which the body gives. But I would be consciously monitoring it, but on the other hand, give about 3 to 4 GIR for this baby and keep monitoring. I don't think we need to be in any sort of a rush to keep, start insulin or start reducing it immediately. That can also be detrimental. In other words, I would say I would keep it as a reserve, keep analyzing, keep looking at the stress factors, try and reduce the stress. Say, for example, this baby is extremely septic. Give good, appropriate dose of antibiotics. This baby is in severe pain. Give sedation to make sure that, or analgesia to make sure that you relieve the pain. So take away as much stress as possible from this baby. Look at the response from the baby. If it is still bad, even then I wouldn't do anything much. I would just say give GIR maybe 3 to 4 and then keep assessing. Hypoglycemia, on the other hand, in these circumstances, is even detrimental for me than hyperglycemia.
Yeah. So Dr. Pratap Chandra, because there are 9 questions regarding the hyperglycemia, let me just conclude what you told. Yes, there are so many, 9 people have asked about the hyperglycemia. So hyperglycemia do occur in birth asphyxia, yes, because of the stress. At the same time, therapeutic hypothermia also induces the stress. Therapeutic at the same time, because therapeutic hypothermia will decrease the cerebral metabolism. That is the reason cerebrum is not able to take the glucose. At that time, brain will start taking the glucose from the lipid metabolism. That lipid metabolism, that glucose is not able, that is having insulin resistant hyperglycemia. It's because of the lipid metabolism. That is the reason here some people have tried the insulin, that is not able to work because it is insulin resistant hyperglycemia. That means the death rate will increase. Lipid also started acting because of severe lactic acidosis. So the people should know, because here already therapeutic hypothermia is pushing the potassium inside the cells. At the same time, if you give the insulin, that will have a more problem. Thank you very much. The second thing. So Dr. Pratap Chandra, once again, PCO and PO2. Tell me in 2 words about PCO2, PO2 and ABG, what we are going to do, how to assess. Partial pressure of carbon dioxide, partial pressure of oxygen, how to assess in ABG in therapeutic hypothermia. Dr. Pratap.
Oh, I think, all the blood gas analyzers are using normothermia as when it interprets the blood gases. So it can be falsely low. So therefore, you need to look at baby's condition. It can be falsely high, I meant. It can be falsely high. And you can be looking at the baby's condition and whether it is breathing really faster or not. You again tweak it. Your oxygenation and your CO2 is your acidosis is dependent on your hypoxic levels. So make sure you adequately correct the hypoxia. I would take your ABG machine value with a pinch of salt. I think you can add a little bit more. Dr. Dinakar looks like you add a bit more.
Yes. Yeah. Dr. Pratap, thank you very much. The thing is here, two people have asked about the PCO2 and PO2. Thank you very much, Dr. Pratap. See, it is like this. Definitely, when you will cool to 33.5 degree, what happens? The blood will keep the oxygen 4% inside the blood. 4%. That means if it is 35, whatever the 4% out of it, it will keep inside. PCO2 will have 7. Sorry, not percentage, 7. 7 means if it is 30 means 37. So oxygen, what happens? Everything it keeps inside the blood at the time of hypothermia. When you will take the blood from the baby, when you will go to the machine what it will do is it will calibrate at the 37 degree. 37 degree. That means whenever the patient will get 37, suppose if the patient inside the blood is having 37, it will show 37 plus 7 PCO2. Around 42 or 44 it will show. But inside the blood it is only 37. See that is the reason always PCO2 is more determinantal, PCO2. Because what happens is if it is in the blood 40, in your machine it will be showing 47. So don't think it is always less. I mean, in the blood, it is less only. So what you people have to do is, if the PCO2 is very high, PO2 will come down in the cerebral vessel. This thing will occur. At the same time, what happens? 3 things will happen. Number 1, PCO2 is low. Threshold for the seizures will come down. Baby will throw into the convulsions. Please, when you do the ABG, see that ABG will maintain 45 to 50 PCO2. That is one. One more thing, Dr. What is his name? Dr. Rajat, how are you going to treat about the EPO? What is the dosage? What is the duration? Why hypertension will develop in the EPO? How can you treat hypertension, EPO developed hypertension? Because EPO, there are so many dosages are there, so many regimes are there to treat. Dr. Rajat.
So right now, what we need to understand is EPO is a promising therapy. It is not a therapy that we need to think of using with a particular dose in mind, mainly because we have not determined what dose works best. So people were using 300, now they're using 1000 units. And people are also using it on day 1, day 2, day 3, day 4, and then day 7. So if you just Google HEAL trial protocol, so it comes up. I had it on a slide, I had to cut down on the slide, so I'm not bringing up my screen again, but you can do it on your device. So HEAL trial study protocol, you can look at it. So that is the high dose. Okay, so the safety seems to be okay with that. But as Dr. Dinakar is suggesting, there are lots of side effects that have been seen in adult intensive care units which have used them. So we have to be extremely cautious. EPO is available and EPO seems to be working slightly independently of cooling for people who are not cooling. So we should not be using it as of now. So there is a analog of EPO, synthetic analog, which can be used as weekly doses because of the half-life and other pharmacokinetic measures that might be more suitable and more safe. So in just one sentence, the answer is we don't know. Study protocols are only available and we should wait.
Yes, sir. So there are 3 people have asked about the EPO. So people have said it 1000 units per kg to up to 5000 units, but many people have tried with 1000 to 2000 unit, 2500 unit, 1000 to 2500 unit per kg. Alternate days they used. Some people have used 1, 2, 3, 4, 5, 6, like that 7 doses used. Some people have used for 7 days in alternate days. Okay, that is the EPO. Only complication is hypertension. Decrease the dosage. See the BP. Keep the mean BP in a normal posture. Suppose if it is rising, decrease the dosage or stop the dosage, or still further decrease the dosage. If the hypertension is more, it is only arterial hypertension. Use the arterial hypertension, anti-arterial hypertension drugs. Okay. So Dr. What is it? Doctor. Okay, I think so. I don't know whom to ask this question. Role of theophylline and acute kidney injury. I don't know whom to ask this question.
Role of
theophylline in acute kidney injury. I don't know. Somebody has asked me this question. Please, sir. Anybody?
Theophylline has a
theophylline,
correct? Theophylline has such a narrow therapeutic index in neonates it's not a drug to be used. Acute kidney injury should be managed in a way that you would do fluid restriction, you would manage with restricted potassium intake. Are they using it to negate potassium? I don't know. So they're using it to negate.
If I can take up that answer question, Rajat, there were few trials initially where they tried theophylline and they said that it might reduce the acute kidney injury in babies with perinatal asphyxia, but has not been proven. We had done some 10 years back. We also did a small thesis on using theophylline, but it did not work. So the answer is theophylline does not have a role in AKI in HIV.
Yeah, so Dr. Bidari sir, you got the answer. Okay, Doctor, anyhow, Pradeep, you are online. Please, for you, one more question. AEEG, other than HIE, can we use anywhere, sir? Dr. Pradeep, that's a question for you.
As I told you, it can be used in any other neonatal seizures. It can be used with babies with metabolic encephalopathy. It can be used in babies with bilirubin encephalopathy. It can be used in babies with meningoencephalitis. So any neuroinfections, any encephalopathy other than HI, you can still use it.
Also, just if I may add into it, also amplitude is also used in cases where you had to paralyze a baby. For example, baby hasn't got a HIE, but baby has a severe PPH and you have paralyzed the baby. You don't still know the neurological status of the baby. Even in those circumstances, amplitude EEG is helpful. In some units, people have started using it as a default in cases of paralyzing the babies.
Yeah. So, Dr. Pratap Chandra, be on the line, please. You got one more question. Why subcutaneous fat necrosis will occur? Number one. If it occurs, why hypercalcemia will happen in the later stages? Please, Dr. Pratap Chandra.
First part of it, I didn't get it.
Why subcutaneous fat necrosis will occur in therapeutic hypothermia? Number one.
Why?
The second question is why hypercalcemia? This is from North Indian person. He is a postgraduate. Yes, sir.
See, subcutaneous fat
necrosis
is common in cases of direct contact of extremely cold material to the skin. It can happen to anyone, even if you keep the extremely cold material for longer periods of time. The fat around that area will necrose. So that is as common as that. So it's as simple as that. Therefore, the newer therapies involving, say, for example, Criticool or they use the wraps, and then you also use a little sheet in between that. Okay, so this is to negate that effect of direct contact. And majority of these newer ones will. I have not seen. It's very, very rare for us to see the necrosis, fat necrosis. Also, Rajat pointed out that you should keep changing the position of the babies as well. So whenever the babies are put under pressure, like a pressure, effect on the baby, along with cooling, that area also is known to have fat necrosis. I don't think it should be a major thing, So fat necrosis, we are not seeing that much. Plus, don't use ice directly in connection with the skin of the babies, especially if you're doing passive cooling.
Yeah. Hypercalcemia, it will develop. Is it to treat anything can be done, Dr. Pratap Chandra, or anybody, sir? Okay.
I don't
sir,
think.
One more thing. Yes, sir. Yes, sir.
See, subcutaneous fat necrosis can also be seen with hypercalcemia. That is the idiopathic subcutaneous fat necrosis, not the subcutaneous fat necrosis that we see in cooling babies. So there are two different issues.
Hypercalcemia without necrosis is usually not seen in asphyxiated babies.
Yeah. So Dr. So with the permission of this thing, Dr. Prashant and Dr. Pratap, can I add some more words, my dear?
Yes, please. Always.
Yeah, please. Dr. Pratap, the subcutaneous fat necrosis do occur even in the birth asphyxia. Number one, because of the abnormal blood circulation and decreased circulation to the fat. Because subcutaneous fat contains stearic acid and palmitic acid. That stearic acid and palmitic acid do, when we will cool that baby, because of that coolness, it will become a crystalloid solution. That crystalloid solution will cause a redness and inflammation. So it is a number one, that because of the two things, it will have a subcutaneous fat necrosis, then first light, but it is a steroid. So because of that, what happens? Calcitonin that is produced in the thyroid gland C cells, it will reduce very heavily. That is the reason hypercalcemia will occur in the later time. That is the reason hypercalcemia due to either sepsis or therapeutic hypothermia. In the hypercalcemia treatment, we do use high dose of calcitonin. So that's all the things. I think so. It's a very good. I heard a very nice talk from Pratap Chandra. It's a beautiful talk. Dr. Pradeep, as usual, excellent. Rajat, beautiful talk. Sir, Bidari sir, you have enlightened our knowledge the way when you have done and went to Israel and bought the machines. And sir, thank you. Over to Prashant.
Prashant, hello.
Yes, sir. Guru Prasad, sir.
Yeah.
Yes, sir. Yes,
Yeah. I think I should congratulate all the speakers on a very relevant topic. I have just a point to share and a question to all the panelists, Prashant.
Yes, sir.
Yeah,
Please.
Dr. Sheeta Shankaran and Gluckman are the most widely quoted references for all the research in therapeutic hypothermia. And Sheeta Shankaran is an Indian-based neonatologist working in USA. I think we should be very proud of that. She had come 7 years back for an annual convention of NNF at AFMC Pune, and it was a pleasure hearing to her. I think something which we have to proud of at this moment is the original research for therapeutic hypothermia is by an Indian-based scientist in the United States. I think we should be very proud. I have a question to Pradeep and for all the panelists. It is good that all units have started cooling and all the speakers are working in different setups. I guess Dinkar can just conclude this. How much does it cost each baby in different, these are all corporate hospitals. Pradeep is working in a medical college hospital. Dr. Bidari is working in a tertiary center, and we are also cooling for more than 5 years now. I just want to know, out of curiosity, parents ask, like, how much does it cost for ventilation? How much approximately it costs parents therapeutic hypothermia? And a specific question to Dr. Pradeep. Good that you made the augmented EEG very simple. Is there any clinico-electrographic correlation of types of seizures? How good it is in picking up subtle convulsions in babies with HI and other causes?
Sir, I will answer your first question. The cost of cooling in our unit, we are charging a comprehensive or a package of 20,000 for complete cooling package of 72 hours. This excludes the NICU care, sir. So whatever is the basic NICU care will continue, and we will be adding another 20,000 as a package for 72 hours plus 6 hours of rewarming as the cost.
Thank you.
And coming to your second question about, sorry sir, I missed the first part. What did you ask?
Clinico-electrographic correlation. It just says there is a seizure. How does it correlate with subtle convulsions and different types of clinical seizures due to different etiology?
So the major problem is only 30% of the electrical seizures are associated with clinical activity. So the major problem is, especially once you are loaded the babies with phenobarbital, is you lose the clinical electroclinical dissociation happens to the extent of almost 60 to 80%. So after once you have loaded them with phenobarbital, there is complete loss of clinico and electrical correlation as such. But before that, it's only whenever the people have looked at, it's only about 30% of the seizures were actually had both clinical and electrical activity.
Fine, thank you.
And sir, third question you want to ask again, sir?
Yeah, same thing. Clinico-electrographic correlation. Yes, yeah, Bidari sir, how much it is costing in Bijapur right now?
Bidari sir.
1 second.
Yes, sir. Question for you.
Yeah. We don't charge anything for cooling, but only thing the wrapper costs about 8,500 to 9,000 rupees that you have to pay, and we charge only for NICU stay and the ventilator. We don't charge for cooling. We don't charge. And it comes to, if the baby is on ventilator, it comes to about 8,000 to 9,000 rupees. If the baby is not on ventilator, it's about 6,000 to 7,000 rupees.
Okay. Just it is out of curiosity, the junior neonatologists should know how they have to translate their knowledge. How should I change it into practice? How much approximately it costs? Because they are working in different setups, This is an important practical point. Most of them ask often.
The only thing is, if you use nitric oxide, our latest this one for then the charge will be something different. We charge for nitric oxide.
Pratap and Rajat, can you just one sentence?
So nice to hear from you, sir. Thank you. So very similar, actually. I mean, although I work in a corporate hospital, very similar to what medical colleges are doing, because asphyxiated babies usually are born in circumstances where affordability is a major issue. So if at all, I mean, kind of similar things, like Dr. Bidari is doing an excellent service by completely subsidizing it. So this is one of the things that got our management to subsidize. So we charge 25,000 in addition to 20. Dr. Pradeep said 20, so 25 was the thing. Can I just add on?
Dr. Guru Prasad, sir?
Yeah, I am online.
So can I add on something about?
Sir, you asked one thing. No, Dr. Bidari was asking he will charge for the wrapper. Sir, why it is very important. The wrapper, what critical people or other people are giving, I don't know other people. Critical people are giving that wrapper every 7 seconds. It will decrease its pressure. The water flows in the wrapper, comes back every 7 seconds. It will decrease its pressure. That is the beauty of that machine and that wrapper. That is the reason subcutaneous fat necrosis will not occur. That is the reason they are using servo controlled, and that wrapper is more better.
So just a point on amplitude integrated EEG. It has all the disadvantages that regular EEG has, sir. The only thing is it is easy to interpret. Subtle seizures are, if at all they're picked up, they're usually wrongly picked up. Because this is a integration of the whole voltage in the entire brain. So it is just an amplitude, it's compressed. So during seizure, it really gets excited, it goes up and then comes down. So that is a most definitive way of interpreting a seizure. But the latest machines also have a scope for you to actually observe the, at that point, wherever there is a peak, you observe the thing. Fortunately enough, we are having machines which are slightly more affordable in terms of AEG coming out now, but not all of them are good.
Thanks, Dr. Guru Prasad, sir. I just want to add in here. I think we are a corporate hospital as well, motherhood hospital, chain of motherhood hospitals. So basically, as Rajat was pointing out, it happens majority of the time in low socioeconomic group. When we looked at our cohort, the whole motherhood group, we got 3 babies who needed cooling for the last 2.5 years since I've been there. So all of them have come from low socioeconomic background, apart from 1 or 2. So if they don't have insurance, I think we have the standard intensive care cost for poor babies. On top of it, we charge anywhere between 5 to 15,000 for the cooling specifically. But what happens is, to explain to the parents to start the cooling itself, it is very difficult. When we get a call, they'll first say, what is the amount? You just tell me first what is the amount, then only I will come. So it is as if they're doing favors to us, So at the end of the day, what we have done is having a package of, say, for example, 75,000. It can vary, 60, 75,000, including everything, total body cooling and intensive care and all of it, consumables, whatever you name it, for 3.5 to 4 days of intensive care. And beyond which, it depends on whether the baby is going to stay with us or not, whether the baby needs MRI or not. Those things are all taken as extra. So again, it varies. A lot of times we were not.
Dr. Pratap, Chandra, you have one more question here.
Yeah.
Yeah, Dr. Pratap, you have one more last question.
Yes,
from Dr. Sidhu Charki, great person. Intensive phototherapy in cooling babies. Especially for you, he has asked.
He had asked me the NCAT as well. So I think, a lot of phototherapy, how does it work? It works on your bilirubin coming and sitting in the subcutaneous area. And majority of our cooled babies will have a lot of vasoconstriction, and bilirubin might not be concentrated in the subcutaneous area. So this is a very tricky question. I think phototherapy should be definitely given. Okay. But only if you're thinking of it's very, very, very high. Like a rhesus disease, and in those circumstances, when you think that not giving it, or rise of bilirubin more than 0.5 milligrams every hour. Those are the circumstances you need to be really worried about. I'm more worried about, not worried about your regular physiological jaundice and all those things. Rhesus isoimmunization, yes, I'm really worried about. And if the bilirubin is high, I do treat. Whatever, you can actually, when you critical jacket, you can just open it and then keep giving whatever the surface phototherapy that you have. But I'm that not least
This is a lot.
bothered about it, actually.
Okay. Yeah. So you can give according to everybody. The thing is, any studies comparing critical and miracradle to anybody can take. Whoever wants to take, please take. All the 3-4 speakers.
No, looks
I
like you want
also got
to
the same question.
Studies, miracradle and critical.
They are asking questions that now, since we have got an idea about cooling and everything, which one to buy, which one the individual people are using who are there in the panel, and what is their say about their experience about the equipment, what they're using. And
So
they want to get an
I'll
idea about which one to go about. Yeah.
I'll start with this. I'm using Critical right now, and we are probably the first ones to have the mini Critical in the whole country. The mini Critical is as small as your Ticothum, and it is crash tested and everything, and is compatible to be used in the transport. So one of the guys had asked the question, 300 kilometers, how did you guys do it within 6 hours? We just did it because we took the Critical machine with us and started the cooling local area and then brought the baby. Until that point in time, they were doing passive cooling. So Critical I've used in UK as well, which is a big one, the big machine one as well. So I think I've not had any major problem at all. One other area we also use this machine is during surgeries. I think this is one thing that our experiences. Rajat can also vouch for that. During the surgeries, a lot of times if you're using the AC, especially if it's a preterm baby undergoing surgery, and even in the term baby, the temperature can drop because you are not, most of the times you're doing the surgery under the warm heater. So therefore, you can use this Critical machine and then control the temperature of the baby as well. So that's from me.
We have both, Prashant. We have critical and
Medical issues. Medical legal issues. Dr. What is it? Dr. Rajat, it is for you. If we don't cool in asphyxiated baby or medical legal issues, anything Dr. Rajat.
Correct. See, right now there is no position statement from NNF or IAP making it a mandatory thing or a standard of care. So in this day and age, because there are anecdotal cases where people have litigated, what we should aim at is to offer the parents that this is a treatment that they might want to avail, and this is the way to go about it. The nearest medical college which does, or so on and so forth, and explain to them the pros and cons of going for the treatment and record it. And I think if we have done that, then you should be safe. But in the best interest of the baby, I think the baby, if possible, should be sent to a cooling center. So that's my take.
So, Dr. Pradeep, are you there? Dr. Pradeep. Okay. Dr. Pratap, are you there?
Yes, sir. At your service.
Yes. So suppose if the baby is having jittery while cooling, what you will do? From
what is
I cannot see. So, if it is having jittery or fibrillates, what you are going to do?
Tremors, I think they mean, correct?
Fibrillation.
Baby is having shivering.
So what she is asking is jittery.
Oh, jitteriness. Okay, it is. We have observed shivering in lots of cases, right? So some of the cases, if the babies are having shivering, even the machines will try to see, because shivering will increase the temperature of the body of the baby. Machines will automatically control that, the servo controlled machines. If the baby is shivering too much, sometimes we may have to give comfort to the baby. We may have to use, in some cases, whether there is any painkiller or whether there is any mild sedation. Unfortunately, in India, the Oromorph is not available. This was used very much in UK when we were doing the trials and all those things. So shivering is seen in the babies. It's not unusual.
and you can comfort these babies also by keeping some sort of a heaviness. You can make it with the cloth, like a hand that you used to get it in other places. You just put the hand on the baby, an artificial one made out of, even you just fold a lot of sheets and things, and then you just keep the baby hand on top of the baby. These are some of the things that we have done. I have not experienced any major issues with shivering per se.
So we have to be careful to differentiate it from a seizure or a abnormal motor phenomenon and other thing. But sedation usually works, and if you give morphine at a lower dose, these babies' respiratory drive is not that suppressed. If the baby is not ventilated, if you are ventilated, I think you should be fine. If you're not ventilated, a very small dose of morphine or fentanyl infusion actually works. What I would caution against doing, for people who don't have access to opiate,
Rajat, I'll ask you one more question.
Midazolam is probably not very good.
No.
Because midazolam is not an analgesia.
Is it fentanyl is better or morphine is better?
In this situation, so the clearance of morphine might be delayed a little bit longer. So if you have the option, probably go for fentanyl. But otherwise, there's nothing much to choose. But I think this point, Dinakar, that people should not be using midazolam. It just makes the baby sleepy, but the pain will never go.
But on the other hand, fentanyl, as we all know, is a very, very short-acting drug. So if you're using it, you should use it as a low-dose infusion, rather than just give one dose and then leave it.
Over to Dr. Prashant.
I think the questions are just pouring in. I think we have shortage of time. Anyways, I think it was a wonderful discussion. I'm sure all of them have enjoyed, because we've got so many questions as well. So thank you very much, all the speakers.
Prashant, once again, can you put that slide, please? Slide, please, Dr. Prashant. Can you put that slide? Yeah.
Prashant.
Yeah. 1 minute. 1 minute. See, this is the machine. It is available. This is the machine. It is available. Number one. And Prashant, can you show the critical? Critical. Prashant.
He's trying.
Yeah. Some very really nice talk. Many people are telling beautiful talk. So this is at present available. Please, all our speakers are, I think so, they are using the same thing. Mini first person to buy. Speakers are also using the same thing. CFM machine is there. Can you go to the next slide, right, dear Prashant? Next slide. Okay. CFM machine is there. That is also having artificial intelligence is there. Please request them. They can give even the camera also set that videography AEG also can be done and show to the parents. So over to Dr. Prashant. Thank you for the gen words. Bye.
So thank you very much. So one last
Prashant,
final
over to you.
comment from all three of you. One last comment. Rajat. One last comment.
No, I was going to say I'm missing the part when Prashant usually announces, please join us for dinner and drinks after this.
we would love to do that. I mean, after such a lovely discussion.
No, Prashant, it's going really well. We
would have invited.
Going really well. Please keep up the tempo.
Sure.
So going well. So we look forward to the Sunday session. Actually, I think Dr. Gautam Suresh is going to talk.
We have one Saturday session.
No, you left even Saturday. Sorry, you left Saturday.
That's Dr. Janki ma'am. She's going to speak on NRP in COVID.
Okay. Sorry.
And Dr. Chandra ma'am is going to speak on delayed cord clamping in birth asphyxia.
Yes. Dr. Chandra.
And then on Sunday we have Dr. Gautam Suresh speaking.
So delayed cord clamping.
So a lot of talks are still there coming up. Thank you very much, everyone. So, sir, it was wonderful discussion. All the participants, we will end the discussion. Have a nice evening.
Kutresh sir is there?
Sir?
Kutresh sir.
Kutresh sir, I'm not sure, sir.
Dr. Bidari sir?
Bidari sir is there.
Prashant Gowda, sir. Good evening, sir. This is Harsha Singh from GenWorks.
Yeah,
Can I please add on a word, sir, before you close the talk? Special thanks to Dinakar, sir, as well as the entire team and the speaker. Thank you so much, sir, for availing us and giving us to be a part of it. Thank you so much for the opportunity, and the talk was really helpful even for us as application specialists to understand the importance of our device when it is being applied on the babies and how the treatment happens. Thank you so much for the opportunity, sir. Thanks a lot, sir.
Thank you. Thank you.
Thank you.
Special thanks to Dinakar, sir, and his entire team, sir. Thank you so much, sir.
Hello, Prashant. Hello, Prashant. Prashant.
Thanks to all the speakers.
Very, very nice to all the speakers have good, very good detailed schemes of hypothermic babies and the even intervention, cost and everything, even transport also. Especially thankful to Dr. Bidari, who is excellent work has been done in North Karnataka. And the team of NNFK Karnataka is working well. And good luck for Dr. Prashant and Dinakar also. And Dr. Bidari, who is organizing academic activities chairman for this KRF Karnataka, he talked all the things. And very nice to hear all the things that today's Dr. Athreya and Dr. Pratap and Dr. Bidari have done the wonderful
Kishore Kumar, sir.
Kishore Kumar has done the wonderful job of giving the very good details in interpretation also. Very thankful for him. Nice to see you all the things once again.
All right. Bye. Good night.
Good day.